Good morning, friends. I am Dr. Anil Awad, Assistant Director, IMA CGP Mumbai Sub-Faculty. I welcome you all for today's Oncology webinar. Friends, this month of October being a breast cancer awareness month, we shall be discussing in much detail about the breast cancer and other topics. But before we start, I request our dynamic secretary, Dr. Pankaj Bandakar, who happens to be a Secretary of Maharashtra State also, to begin the proceedings.
Thank you, Dr. Anil.
Yeah.
I welcome all the speakers and delegates on behalf of IMA Mumbai branch. Friends, as Dr. Anil just informed you, this is a webinar on oncology, and we have very eminent speakers today. Mr. Sanket Parale, Dr. B.C. Kalmat, Dr. Prabha Yadav, Dr. Preem, Dr. Nikhilesh Borkar, and also we have Dr. Rajan Sancheti, who is an advisor of DG Shield, and Mr. Welcome, friends. Last few months we were not having live CMEs, and I think we have adapted well to this format, a digital format of CME, that is webinar. Today's CME will go on in some time now, and I have to give some.
Okay, I will just say the presidential address. Good morning, everybody. Today we are having eminent speakers who will update us on oncology topics, and we also have one cardiology topic by Dr. B.C. Kalmat. This month being the best breast cancer awareness month, we are going to have a lot of detailed lecture on cancer. Cancer per day is uncontrolled division of cells which spreads in the body. There are more than 100 types of cancer that we see. But people think that only the elderly people have cancers, but nowadays we see cancer in the young population, even below the age of 40 years. So we will proceed with this thing. And now I hand over the mic to Dr. Anil Awad, Assistant Director, IMA CGP, for further proceedings. Over to Dr. Anil Awad.
Thank you, President Madam. We'll just begin with the program. We are beginning with Dr. B.C. Kalmat. Sir is intervention cardiologist attached to Bombay Hospital, Jupiter Hospital, and Horizon Hospital. Sir did his MD in medicine from VM Medical College, Solapur, and DM Cardiology from Mumbai University, when he received Ivan Pinto Gold Medal. He is an associate honorary cardiologist at Bombay Hospital, Mumbai since 1999. He is an expert in performing complex procedures, including angioplasty, stenting, balloon valvotomy, permanent pacemaker installation, and other catheter-based treatments of heart diseases. He has performed more than 15,000 angioplasties and 25,000 coronary angiograms with high success rate. He has been actively involved in many medical conferences pertaining to the field of cardiology, either as an organizer, speaker, or as a faculty. He is also involved in many clinical trials conducted at Bombay Hospital involving cardiac drug and new interventional devices. Sir will be talking to us on 12 phases of TCOS. Over to Dr. Kalmat.
Good morning, everybody.
Good morning, sir.
Thank you, Dr. Anil Awad, for a wonderful introduction. Dr. Sujata Madam, Dr. Bhandarkar. Sorry, we could not hear Dr. Bhandarkar, but we know that he's been a very dynamic secretary, and Dr. Anil and Sujata are the backbone of the whole program. And at the outset, I thank IMA Mumbai and also MSD for giving me an opportunity to share the very interesting 12 phases of a new land-breaking trial of TCOS on sitagliptin, actually. You may be wondering why this odd man out among the breast and the onco seminars, but probably understanding the cardiovascular risk and cardiovascular risk in elderly diabetic female ladies are very, very important, because this molecule has come up in a very, very big way in treatment of diabetes mellitus. Earlier to 1995 and 2005, a diabetic drug has to just control the sugar. That's it. Nothing else was required to do. Because if it just reduces sugar, it was thought to be a good drug, and hence people thought that that is the end of the story. But if you remember, in 2005, a very important trial came in where rosiglitazone, which is a new drug, which is the new drug then, showed more cardiovascular deaths and MIs in patients who are using rosiglitazone. Then the FDA, US FDA said, nothing doing. All the anti-diabetics have to be at least cardio safe, if not cardio superior, saying that they have to prove their cardiovascular safety. You cannot have more cardiovascular death, stroke, MI, or heart failure after taking a particular drug like rosiglitazone or earlier other cardiac drugs which were banned like dibenclamide and other things which were taken off. So my dear friends, understanding the TICOS, a famous trial. Why it was a big trial? It was a large trial, took 3.5 years to study sitagliptin, a land-breaking TICOS trial. What was the importance? All the CV outcomes are not same, and there are many unique things about TICOS. So TICOS, as I told you, is one large study with many clinical pearls to share, and here we'll discuss 12 of them. Why? This was a trial which is voluntarily initiated before the US FDA. Though it was sponsored by MSD, but was conducted independently by Diabetes Trial Unit DTU of Oxford and Duke Clinical Research of USA, as they had done many trials like AC, ADOPT, DREAM, EDIT and Excel, UKPDIS, all were done by this DTU. Hence, it is a very, very balanced trial, a pragmatic trial, aims to evaluate safety in the real practice setting, mimicking the behavior of clinicians, especially in India, where there's a lot of inertia on the part of the doctors and more of the patients to start insulin therapy. We are really blessed to have such wonderful gliptins, SGLT inhibitors, and GLP analogs, where all these drugs have such a the CVOT cardiovascular outcomes are so neutral or superior that apart from the glycemic equipoise is in this trial, the glycemic equipoise was balanced. What do you mean by that? Both the arms, the placebo arm receiving other drugs and the sitagliptin arm will be controlled sugar match to match with SBN is being shared. Hence, the benefits of sitagliptin is not only due to sugar reduction, there has to be something else which we'll see in a minute's time. So what was this glucose control in various CV outcome trials seen? The famous trials I've shown you here, the TICOS, the SAVAR, TIMI was saxagliptin, Examine was alogliptin, Carmel was linagliptin, Canvas was the SGLT2 canagliflozin, and the famous empagliflozin, and Declare now dapagliflozin. So these last three are of SGLT2 inhibitors. The first four are of the gliptins. But in India, we have sitagliptin or vildagliptin and linagliptin, and of course SGLT2 we have Cana, EMPA, and DAPA. Beauty is that this study, as I told you, done over 3 years, had a baseline HbA1c 7.2, not like 8 or 8.2, 8.5 seen in EMPA, where high risk patients are seen. Meaning by low risk and moderate risk patients, even an HbA1c reduction of 0.3 was achieved. Even then, what was the outcome was important. The TICOS had the lowest HbA1c at the baseline, saying that even the low risk and the moderate risk patients should be benefited by using this gliptin. So the three phase MACE, all you know is about death, cardiovascular mortality, heart failure, and stroke are very important in knowing any trial. Hence, the reduction of the three phase was 8.3 compared to in this compared in the placebo arm. Hence, if you can see that the EMPA-REG and Canvas, which are SGLT2 trials, which had a 0.8586 reduction in MACE, whereas the gliptins, if they had 0.9 or 0.99 was equal or equipoise, what we say is that they are not doing any more harm than using. The comparison comes between the gliptins alone, when we see that the gliptins uh, and the SGLT inhibitors sometimes loses the significance when the non-assessable CV deaths, the deaths not confirmed to be of CV origin, are excluded. But if they include that, probably the death may be a little higher in them. So in nutshell, impact of this the sitagliptin on heart failure, or it may be in the stroke, or it may be on the death, overall death, everywhere, including the other, comparing the other gliptins, was less. And even in peripheral vascular disease, the amputation rates are less. These are all just the highlight I'm telling you about death, stroke, MI, or peripheral vascular disease in the TICOS trial. So my dear friends, we are focusing on the 12 interesting data sets of the CV outcomes, or the CV outcomes of the TICOS trial, which came in last year ADF 2019, July, made a heavy impact, saying that CV outcome in elderly, with how does it affect the elderly diabetic patients, sitagliptin in CVD and CKD patients, effect of sitagliptin on kidney function and the respective cardiovascular outcome, safety of sitagliptin in patients with heart failure, hypoglycemia is very important, and the progression of glucose lowering diabetes therapy, cause of death observed in TICOS, impact on blood pressures, pancreatic safety, different races, different impact of sitagliptin, and difference in sex outcomes in male and female, and impact on sitagliptin on all-cause hospitalization. All this was studied was called as 12 pearls of TICOS trial, which I'm going through quickly. Is that the first and foremost is, most important is in India is there's a lot of growing age. Earlier we had an average lifespan of 54, 57, now it is 67, 69. So American has 78 or 79 or 80. We have 67, 68. Probably we're going to cross the 70 as our average lifespan. So very important is that what is the comparison of death, mortality and malignancy, or hypoglycemia or bone fracture in these patients using sitagliptin above the age was. So there was no worsening of outcomes seen in elderly patients when they use the sitagliptin in respect to the heart failure admission, death. And also, as you know, all the gliptins have a very, very low incidence of hypoglycemia. So what about the second aspect of sitagliptin with CVD and CKD patients? Can we use easily? Yes. CKD was present in almost 23% of the patients at the entry into the TICOS, and the mean age, renal, this thing was 68.8 ml, and the mean age of duration of diabetes was 13.7, is a very big age. That means the mean age of the diabetes were very in their second, third half of their part of the diabetes when sitagliptin was started, with knowing the outcomes for CVD and CKD. So over the 2.8 years of the follow-up, the CKD participant assigned to sitagliptin had rates of diabetic eye disease, diabetic neuropathy, renal failure, malignancy, bone fracture, pancreatitis, and severe hypoglycemia, similar to those of placebo. And mind you, placebo had sometimes secretagogues and other important metformin therapy in these forms. So the incidence of renal abnormality, renal failure, end-stage kidney disease is not higher, and may be reduced in, definitely more reduced in any of the other gliptin CVD trials like Savortimi and Carmelina. Even Carmelina, the linagliptin trial, which was very much talked after for renal outcomes, even that was comparable sitagliptin in respect to the renal failure and reduction of GFR. And that's why we found there are more patients of CKD and CVD in TICOS than in Carmelina. It's a very important thing, which many of our practitioners, we thought linagliptin means only renal failure patients. No, sitagliptin can be used, maybe a little reduced dose, which is also a boon for the elderly patients with CKD. As CKD was associated with worse cardiovascular outcomes, naturally, any trial you take, anywhere, if the CKD is there, whether the trial with statin, whether the trial with with SGLT inhibitor or a gliptin, all cause death, MI, hospitalization, stroke, everything will be higher. And my dear friends, what did our sitagliptin show? Even at lower GFR, the values were maintained, and even the urinary albumin creatinine ratio was maintained, saying that sitagliptin did not increase the risk of CV events in these CKD and established CVD patients. Very important thing to note. So that was the third outcome in CVD and CKD patients. What was the fourth pearl, my dear friends? What about the heart failure? Because the saxagliptin became suddenly enemy in Savartimi when many patients who were using saxagliptin had to be admitted for heart failure when they use saxagliptin. Was it true for sitagliptin? Well, there was luckily no difference in the total heart failure admissions between sitagliptin and placebo groups of more than 350 patients who had the heart failure. When post-op heart failure all-cause death was similar in both the groups. Hence, it's a very important point to say that the heart failure admissions in sitagliptin arm was not increased, and sitagliptin did not increase the risk of heart failure or other CV events like myocardial infarction or CV strokes in these patients who had heart failure from the beginning of the trial. So that's the very important, because the Savartimi and the allogliptin trial did not have superiority on those in heart failure patients. What are the fifth pearl is that because CV events in the risk of severe hypoglycemia. Another important thing which we are very concerned as clinicians is any occurrence of hypoglycemia, which is very true with the secretagogues, the second and third generations of the secretagogues like glimepiride and gliclazide, and especially glibenclamide, and also drugs like pioglitazone, and also sometimes this was not very high. It was not at all high compared to placebo, because gliptins as such are known to cause very less hypoglycemia, and in that sitagliptin has a very low incidence of severe hypoglycemias. Milders may be seen. That's why the CV events were not increased, and hence the MI, non-fatal MI, and strokes were not increasing. And preceding the significant hypoglycemic increase, when you have very high incidence of hypoglycemia, they cause cardiovascular death. If you don't know, my dear friends, hypoglycemia can cause ventricular arrhythmias, cardiac arrest, and MIs, and vice versa. Very high sugars also can cause the CV events. But more important is severe hypoglycemia causing ventricular arrhythmias, and sudden death in the night in the sleep are seen in these diabetic patients because of arrhythmia. Hence, any drug where it can have severe hypoglycemic acidosis, we are very careful in CV, cardiovascular patients, CKD patients. Hence, the sitagliptin proved that not increase severe hypoglycemia. Chavan, mute the other mics, please. All the mics, please, Chavan. Progression of glucose lowering therapy, was it sitagliptin therapy was associated with 30% lower risk of initiation of chronic insulin therapy? What else do you want? In a group of such large patients, 30% of the patient did not require early insulin usage. Is a very important side effect of sitagliptin, where diabetic medicine extra requirement was not required when the sitagliptin was used. That's a very important saying, that the beta cells are preserved better with sitagliptin, and causes of death, like all causes of death like CV death, sudden death, stroke, MI, all were comparable in TCOS, and they were either less or equipoise. So what are the risk factors for all-cause death and CV death? What was important thing which you saw was every 5-year increase in the age, asymptomatic heart failure, history of angioplasty, and more female patients, reduced GFR. These were very high important factors which had a more significant p-value, causing a higher CV mortality. That's you have to be important. You have to note that. Hence, patients who had an earlier angioplasty or bypass, or who have heart failure, or who are elderly, or who have asymptomatic heart failure also are very prone to get CV risk. You should know that. Hypertension effect may be very small, and then the systolic blood pressure baseline and time of the cardiovascular disease in these patients were comparable. At least if you see the graph at the end here, it was not raised. It's very important, and maybe a millimeter or 2 millimeter was lesser. Hence, you see that CV events are maximum when the blood pressure is very high, above 150, or low, below 70. So, a patient, the gliptin was equipoised in these patients. So, the association with the hypertension was very uniform. Hence, patients with, why we're talking about that? When you use pioglitazone and rosiglitazone, especially pioglitazone and sometimes maybe other drugs where the water retention is a very important thing, hypertension can be increased. Another important thing, when gliptins came, we are bothered about pancreatitis and nasopharyngitis. Pancreatitis and pancreatic carcinomas were uncommon events. Even though numerically you can see little higher acute pancreatitis with sitagliptin use, it may be true for all the gliptins, and acute pancreatitis little higher. But if you use in more than few thousand patients, this numerical value was not at all significant, and probably the pancreatitis can be related to the other disease like calculous disease, gallbladder disease, and alcoholism, and also diabetes itself causing that. So it was not numerically significant, or p-value was not significant in these patients using sitagliptin. So what was the impact in many races? What is important for us is that when we first saw the 4 months of therapy of glucose control in sitagliptin arm in TICOS trial, was that the East Asian and Asian group, we had a 0.6 of HbA1c reduction compared to other people, and hence the Asians required more metformin use and higher metformin use, higher sulfonylurea use, and higher thiazidone use, and lower insulin, because there's inertia. But maybe this is a boon when you are using DPP-4 inhibitors in Asian patients are more effective than Caucasians and Hispanics. Very important, because probably you have more expression of the DPP-4 enzymes at the gut level and many level. And as for the sex difference in CV outcomes, so seen that if you've seen that we had more cerebrovascular disease and peripheral vascular disease in women, but men had more cardiovascular stroke like MI. Women had more cerebrovascular and peripheral artery disease, which is a small difference, of course, not too important, but we should know. So coming to the last pearl of sitagliptin effect on all-cause hospitalization, participants in randomized receive sitagliptin in addition to usual care were hospitalized to 4,800 times compared to 48,000, sorry, to 4,800 versus in this group of among patients. When you randomize, if you see it is 34 and 36, 34.6. What you see that is the hospitalization rates appear to diverge after 2 years with lower rates among sitagliptin treated patients versus placebo, saying that probably the cardiovascular stroke, MI, the cerebral stroke, heart failure, everything was lower in these patients. Hence, TICOS is about the safety of sitagliptin and beyond. What we learned today, friends, is more about sitagliptin safety. Old age, CVD safety is very much there. Whatever the patients already having CVD and cardiovascular as well as chronic kidney disease, it is very safe, very safe. Effect of sitagliptin on kidney function and effect of CKD, no deleterious effects, no worsening of kidney function, great. You can use up to the GFR levels of 30. Safety of sitagliptin in patients with heart failure, very much beautiful. Unlike saxagliptin and alogliptin, no red marks for heart failure. Hypoglycemia, very small, no severe hypoglycemia. Progression of glucose lowering diabetes therapy still persistent after 3, 4, 5, 7, 8 years, very important. Causes of death observed in patients' history of CVD are equipoise, not more. Impact on blood pressure, good. Pancreatic safety, very well seen. No higher marks of pancreatitis. Racial difference, very much there, good for Asians. Maybe females and males have a different advantage. Both have advantage. And impact of sitagliptin on all-cause hospitalization is wonderful, saying that it's a great, great drug with all the possible good effects of sitagliptin. If you ask an ideal gliptin, it should be sitagliptin with a very close run by linagliptin. I would say sitagliptin has a huge data. And my dear friends, with those words, I will stop my lecture here, and I welcome all the comments and questions. Thank you.
Thank you very much, Dr. Kalmat sir. Any question from the panelists? Because we haven't got any question in question answer box, sir.
We have one, Dr. Anil. What is the advantage of vildagliptin? Well,
yeah. Now it has come now. Yeah.
Vildagliptin did not have large trials like sitagliptins, unfortunately. Probably that was Japanese molecules that was studied more in Japan. And we do not have large data at all with vildagliptin. Very small trials are with vildagliptin. Only if at all smaller safety we can say is that we have a lesser, more economical brands are there with vildagliptin. But if you want larger CV safety and larger outcome trial beneficial, it is sitagliptin, especially elderly and CKD patients. That's what I'm saying.
Okay, thank you, sir.
Thank you.
No other questions, and thank you, sir, very much for enlightening us about sitagliptin and the cost.
Yeah, we received one more question right now.
Yeah.
Cost effective of sitagliptin.
But the cost has been, it may be a little higher than vildagliptin and of course teneligliptin. These two drugs are very, teneligliptin was cheaper in India and vilda has reduced now, a few brands have come, but sitagliptin also working on that. It's not as costly as linagliptin. Linagliptin is pretty costly. Sitagliptin is between vilda and linagliptin. So probably we can talk to MSD people to reduce the price for Indian patients. It is not too costly. It is slightly higher than vildagliptin. Earlier vildagliptin were same, but the newer vildagliptins have come down.
Any more questions from the panelists? Okay, sir.
Thank you so much.
Thank you very much again. And we now move on to the next topic. Now we have Mr. Sanket Barale, who is the founder and chairman of DigiShield, who are the people who are providing web platform for all these programs. He is a health IT expert, innovator, and entrepreneur. As the head of the DigiShield, he has pioneered groundbreaking products, processes, and services, and has established partnership with some of the largest healthcare enterprises across the globe. He has, with his enterprising skills, has founded many innovative enterprises in the field of healthcare and technology that focus on developing and delivering solutions for the global healthcare industry. He is also a founder of FIG MD, a Pune-based Google Ventures-backed company that manages healthcare data for 40% of the USA citizens. Over to Dr. Sanket Barale.
Dr. Pachnekar, thank you so much for that kind introduction. Most of these introductions are quite kind in their nature, and hopefully that holds true in my case. So within the context of this seminar, I realize I'm a little bit of an oddball out. So I'm going to try and take a little bit of time, maybe about 5 to 10 minutes, and just talk about digitization in healthcare, and specifically within the context of a complex field like oncology. So let me share my screen real quick. Okay, so I'm having some trouble sharing the screen, but I'll just talk. One of the things that I have done personally is, for the last 5 or 6 years, I've been working very closely with the American Society of Clinical Oncology, ASCO. And we manage, our company manages their clinical data initiatives, registries, and various other topics. And in that, what we have learned is that oncology specifically is a requires a sort of a multidisciplinary approach toward healthcare. Now, what ends up happening is that when you're talking about healthcare and digitization in healthcare, when multidisciplinary approach has to be delivered, care has to be coordinated between an oncologist and a family doctor, or a diabetologist, or a cardiovascular specialist in the treatment of the cancer and all the associated all the comorbid conditions that a patient may have. It becomes very challenging most of the times for this care coordination to occur effectively. So digitization in healthcare, and that's what we are an expert at. The digitization in healthcare has to occur in a manner that's very easy for the patient to interact with, and that's also very easy for the doctor to also digitize. But also, more importantly, it has to happen in a manner where multiple specialists, multiple doctors can collaborate with each other in terms of providing the care to the patient. So when most often in India, what is happening right now is that as healthcare is digitizing gradually, the ability for providers to collaborate across different platforms that they choose for digitization and medical records is very low. So with that focus in mind, we've started working on Digital Shield, applying our international experience and localizing and kind of making it unique to India, to make it very easy for doctors to choose their platform, to choose multiple platforms, and in the case that you choose DigiShield, for that platform to be open and extensible and work with other doctors and and patients that use multiple modalities of digitization. So the need to have a holistic approach toward digitization, the need to have a holistic approach toward care, and a technology platform to enable that a holistic approach is critical, and that is one of the things that we are quite proud of solving at DigiShield. So I would as a sort of a shameless plug here, I would recommend you guys to check out the platform. It is free for all IMA members, and again, appreciate the opportunity to have a couple of words in on this in this esteemed webinar and the panel. So definitely check it out, and let's add a new dimension to digitization in healthcare in India. Thank you so much, Doctor.
Thank you very much, Mr. Sanket Barale, sir. You have always been helpful to IMA, whether it's a Mumbai branch or Maharashtra State branch. Thank you very much.
Thank you so much. Yeah.
Friends, breast cancer has been on rise, and alarmingly, more and more of the younger population is being affected. So in this scenario, breast reconstruction and preservation is of utmost importance in breast cancer management. And to talk on this very important subject, we have Dr. Prabha Yadav. I'll just briefly introduce Dr. Prabha Yadav. Dr. Prabha Yadav is the Director of Plastic and Reconstructive Surgery at Sir H.N. Reliance Foundation Hospital and Research Center. She completed her MBBS and MS in Plastic Surgery from University of Mumbai. She got trained in microvascular surgery at Brescia, Italy. She was Associate Professor in the Department of Plastic Surgery at Grand Medical College and JJ Hospital, Mumbai. She has been the head plastic and reconstructive microvascular surgery at Tata Memorial Hospital, Mumbai. She has trained over 150 reconstructive microvascular surgeons in India as well as in abroad, and is instrumental for current reconstructive microvascular surgery in India. She was the past president of Association of Plastic Surgeons of India. She has good number of publications as journal articles and authored book chapters. She has performed over 5,000 free flap reconstructions and has penned down this vast experience in a book titled Mastering Cancer Reconstructive Surgery with Free Flaps. Dr. Prabha Yadav, so you can just begin your talk. Thank you very much.
Good morning, and thank you, IMA and all the faculty, for giving me this opportunity to share my experience with all. Thank you for the kind introduction. And this is a good platform because this is a plastic surgery, breast cancer awareness week. As we all know that breast cancer is the most common cancer of India now. It has surpassed CS, cervix and the oral squamous cell carcinomas. Presently, the patients present between late 40s or early 50s because of our middle-age pyramidal system of population. Due to increased awareness and advances in various diagnostic techniques, early detection has become possible. With different modalities of treatment, it has become possible almost to get cure from the disease. And hence, the whole aim of treatment, that is quality of life, has become important for the patient. Surgery, as it is a multimodality treatment, but surgery is the main modality of treatment for breast cancer. And depending on the disease or its aggressiveness, it may require a breast conservative surgery, that is a lumpectomy. Only the affected part of the breast will be removed, or a mastectomy when the whole breast is removed. These surgical procedures usually result in a deformed breast or no breast at all, and that affects the quality of life of the patient involved. These are the few photographs where no reconstruction has been done. This is for breast conservative surgery where the lumpectomy has been done and it has been closed primarily, or when the mastectomy has been done, and this is what patient has to undergo if the reconstruction is not done. So why should one reconstruct breast? It is the most revealed sign of femininity, and it's the individual's body image or her self-esteem. The lady may feel incomplete without one breast or the deformed breast. And this deformity, anytime she looks herself in the mirror, is a constant reminder of the disease. So why should a lady undergo this? So the breast reconstruction, there are a lot of techniques that have evolved a great deal over the last several decades. And woman must live without a breast is a notion of the past in the present era. What is breast reconstruction? It is nothing but recreating the mound matching to the other breast, or in a bilateral reconstruction, recreating symmetrical breast. Anywhere, anytime you have two structures in the two similar structures in the body, they need to be symmetrical with each other for aesthetic purpose. So this to begin with only, I'll say that these are purely cosmetic procedure. Breast reconstruction is a cosmetic procedure. It looks or feels like a breast, but it does not function like a breast. But for the quality of life, you can call it a functional reconstruction. There are different options for reconstruction that can be divided into mainly three categories. That is implant-based. It's an foreign material which is used for reconstruction, or using patient's own body tissues. Or it could be combination of the two, implant and body tissue, flap cover for that implant. So breast reconstruction because nowadays it is early detection and usually offered a breast conservative surgery. So we'll require a partial breast reconstruction, or whenever a mastectomy has been done, we'll require an whole breast reconstruction. Or there is a terminology called an oncoplasty. What is oncoplasty? Oncoplasty is nothing but using plastic surgery principles in synchrony with oncological principles to achieve good cosmetic outcome after breast conservative surgery. That means any lump has been removed. Ultimately, you will adjust the tissue in such a way that patient gets a good mound over there. So these techniques are volume displacement technique when you have a sizable breast, or this could be volume replacement techniques when the breast is small or the resection is extensive than what can be used. So these volume displacement techniques, that is partial breast reconstruction, like I said, is indicated when large breast tissue is removed compared to the remnant breast, usually in a small to moderate size breast. Most favored flap used for partial breast reconstruction is the latissimus dorsi myocutaneous flap, or its perforated-based flap, that's called TDAM. It is a muscle at the back of our chest, which is supplied by an thoracodorsal vessel, which can be easily flipped anteriorly for the breast reconstruction. Or there are multiple perforator-based flaps based on the intercostal vessels or the epigastric vessels in the vicinity of the breast. I'll show you a few of the reconstructions done with the LD muscle. LD is a long muscle which can move in any quadrant of the breast. So this is one such defect where there is an upper outer quadrant defect, if you can see, and this is the marking. Usually for aesthetic purpose, we can mark it in an horizontal paddle on the LD muscle so that it goes in the blouse or the brassiere area. So the patient is not worried about the scar at the back. And this is how it comes and it replaces the lost tissue. This is for the inner quadrant, inner medial quadrant, where another LD myocutaneous flap has been shifted. This is early post-op on table. And this is for the central, when the NAC and the central quadrant has been removed. Again, an LD. This is how it is marked, and that comes as an pendulum and gets inside the defect. And the donor area is closed primarily. This is a little bigger size central quadrant defect of the breast with nipple areola. And this flap is shifted ahead. We usually take skin, which we can close primarily behind and shift it ahead. And this patient at a later date, if she opts for a nipple areola reconstruction, can be done once everything has been settled down. These are little odd defects. Still, LD is a good enough pedicle flap to come ahead. That's the defect, and this is how a flap has come in. And see, this is the long term. In the front view, you are barely able to see it, and this is a well settled LD flap for the partial breast reconstruction. This is when the whole skin has been spared. There is no need to remove the nipple areola. So this, again, we take it as an LD flap, but we deepithelize everything and bury it. So if you look at it, you will not be able to realize that this breast has been reconstructed. So there are certain, like I said, there are intercostal perforator based flaps. Now they are gaining popularity. This is one such defect, but this is very early post-op, so I won't be able to show you a long-term defect. This is the breast and that's the tumor. And that's the perforator marked on the lateral side of the breast. That's the defect. And this is flap, which is totally reepithelized and then buried and pushed, and the donor area is closed primarily. Another one where you can see there's a tumor is there, but as much as the skin has to go, that's the excised specimen. And a nearby perforator base flap has been marked, and this is deepithelized and again buried inside, and that's just relatively late post-op picture. But these perforator flaps are usually good for the periphery defects more than the central quadrant defect. Now what I said about the volume, these are all volume. These are all tissue brought in from the different site. But when you want a displacement technique is there, it is possible when the breast is of relatively large size. No outside tissue is brought in. It is remolding and reshaping of the remaining breast tissue based on the principles of rotation flap or mastopexy, and the main principle behind the reduction mammoplasty techniques. So whatever tumor needs to be removed, that thing the design is modified so that it comes in whatever tissue we need to remove for the reduction mammoplasty. And its modification can be done to perfect the size and the location of the defect. So this is one such patient. This was the pre-op pictures, and these are the post-RT pictures of using the reduction mammoplasty techniques. So you don't have to bring in any tissue from anywhere else, and the patient gets a relatively younger looking breast. Now when you go to the whole breast reconstruction, there are, like I said, it can be implant based. It can be only autologous tissue, that is patient's own body tissue from somewhere else, or it can be combination of two. So this is like when the skin sparing mastectomy has done, patient was not willing for any major surgery and she wanted an implant. So this is how an implant looks. These implants you cannot just, because these skin sparing mastectomy skins are relatively thin, and you cannot put implant just behind the skin. So you need an additional protection to come over that implant, between the skin and the implant. Abroad, you have an ADM, that is artificial dermis material, but that is not allowed in India. So what we do is we bring an LD muscle from latissimus dorsi muscle from the back. It is required only muscle. So this muscle comes through the axilla into the defect, and that covers this implant behind the skin. And this is her late post-op. Now, patients are willing for a reconstruction, but many times patients are not willing for a symmetrizing procedure on the other breast. So whenever you have two structures, like I said, you should have a symmetry, that only aesthetically it looks nice. But many females don't want that other breast to be touched. They are just interested in getting a mount behind their clothes. So though they are happy, we as a surgeon may not feel very happy with this sort of a reconstruction. There are pedicle flaps which come in for whole breast reconstruction. That's an most favored flap initially was a pedicle tram flap. Tram is a transverse rectus abdominis myocutaneous flap. It is the lower part of the abdominal skin which is used for this. And this is based on one of the rectus muscle. And the whole skin paddle is tunneled into the defect, and this is how it looks. But this slowly, I mean, it has its own problem because it is not based on the main dominant blood supply. So sometimes you have issues of partial skin necrosis or something, and you're taking one big muscle of the abdomen, which is can give rise to a slight morbidity to the abdominal wall. So it is very not routinely used flap. The another flap is an LD, which we have seen before as a sort of a mini LD or primary closure LDs. This is where an whole breast reconstruction is also possible with an LD flap. But only thing you need to check is whether the patient has an adequate amount of fat over the muscle. So this is how defect was created, and this was the skin paddle. And what marking you see around here is, we call it as extended LD. There are two layers of fat, so superficial and deep. So superficial fat is left on the skin, and the deep fat is taken along with the muscle. So you can get almost 250 to 300 cc of fat with that. And this is rotated forward, and this is how it is. Even post RT, it has stayed very well. You do have some counter deformities at the back, but that is usually in the hidden territory. But this is an pedicle flap, no monitoring is required, it's quite safe. Like I said, now, initially patients were not willing for reconstruction itself. Now they are willing for reconstruction, they were not willing for symmetrizing procedures. But now somehow we have been able to convince the patients, and they are also okay with it. So we are doing a reduction mammoplasty to the opposite breast. So all our reconstruction techniques are comparable with the opposite breast if the opposite breast is there. That's the benchmark. So if a patient is willing, we do the reduction of that breast. That's the skin paddle. That's skin paddle is brought here, reduction mammoplasty. That she had a slight issue with the skin, but that settled down over a period of time. There are lower abdominal flap. That's we call is deep inferior epigastric artery based flap. It is the gold standard for using for breast reconstruction, because usually there is laxity on the abdomen. It feels and it's soft, fat consistency almost matches to the breast. So that's a gold standard. So first flap we will look for is the lower abdominal flap, if the laxity and the adequate subcute fat is there. Otherwise, we'll have so many different sites that you can use from the buttock region, S-gap, that is superficial gluteal artery perforator flap, inferior gluteal artery perforator flap, or gracilis myocutaneous flap, or lateral thigh flap. I mean, there are a variety of flaps. If you're taking it as a free tissue, you can take it from anywhere. Only the donor area should have an adequate bulk present over there. This is, like I said, deep inferior epigastric artery flap is lower part of that. So we usually pinch that area and see how much we can use. And the rest of the abdomen is mobilized after the flap, and then it is closed, and you get a scar which goes in the almost like a cesarean scar in the undergarment area. And patient gets an tummy tuck down. So this is one such flaps. Initially, the tram flap was this. Tram is transverse rectus abdominal flaps. The whole muscle was taken, but then it had a morbidity. So the slowly to reduce the donor area morbidity, the concept of an perforator flap, that the vessel which is supplying skin and sparing the muscle and its innervation, so the donor area morbidity or the abdominal wall weakness is not there. So this is dissected to its main vessel. That's how it will look from the undersurface. That's only the perforator and the main vessel. And this is used for the reconstruction. So we join that blood vessel to the blood vessel in the chest wall, usually the internal mammary vessel or the latissimus dorsi vessel. This is how it looks. And gradually over a period of time, it develops nice doses. And this is how an well-healed scar. So patients usually are worried you're taking a flap from the abdomen, whether we will have some problem. But we say that it is like buy one, get one free. So you are getting a breast reconstruction, and along with it, you're getting a tummy tuck done also. So this is how it was preoperative, and this is how it is, almost matching to the other breast. Now, like I said, there is reduction mammoplasty done. So this is one such patient where the skin was spared. So we have to just deepithelize the rest of the skin, what we have taken it from this flap. And this exactly comes over nipple area region. And this at a later date, if she is interested, we can do even the nipple reconstruction over it. Whenever there is a bilateral mastectomy has been done, the same tissue, DI, both sides of the abdomen on the separate vessels can be used for bilateral reconstruction. And this is one side we had required the skin. So anytime a skin from a different region moves to a different part, there will be always a little mismatch. So it will look like a little patch over there. But when you have preserved the normal breast skin, that's the best time to do reconstruction because original skin is preserved and you can't really make out that something has been done because the flap which goes in is totally deepithelialized and buried behind. That's the long-term follow-up. It is not that you can do this reconstruction per primum. You can do it even after many years after the mastectomy has been done. But only difference is if you have done it per primum, this skin which when you do the mastectomy, skin sparing mastectomy also, you can't leave an hanging skin if the patient is not willing for reconstruction. So they need to remove it and close it. So in that case, when you do it secondarily, you always need to bring skin out to create the mount. That's the envelope. Well, there are certain different sites, I'd say. This is like taking it from the buttock region. That's the reconstruction, but the patient was not willing to touch the other breast. This is like gracilis myocutaneous flaps. This is taken it from the medial side of the thigh, upper part. And this is relatively early post-op, but as the time goes, this will develop a ptosis matching to the other breast. And the donor areas are always closed primarily. Now, breast reconstruction scenario, what is in Indian scenario? In USA, almost 40% reconstruction rate is there. UK, it is about 30%. And India, I think I am giving a very upper estimate of 3 to 4%. It is barely, I think, 2 to 3%. I will tell you the data statistics. This is the number of cases that we have done and see the number of breast reconstruction. But if you can see it, it is slowly increasing in number. I think it took quite some time to convince the primary surgeon to make the patient aware that reconstruction is possible. And slowly that happened. In our place, the decision-making process, whenever a breast patient comes, we explain everything, what we can do, what are the problems, what are the advantages, disadvantages. But usually there is lack of awareness that they don't know that reconstruction is possible. Many times it is, a surprise is shown when we say that it can be reconstructed, or there is an additional cost involved. And many times still in our state, our culture, family or mainly the husband decides whether a lady will undergo reconstruction or not. Primary physician, your family doctor or whoever sees you first, I think has a lot of influence on the family and his decision can change that. Why you need to have, why you don't do it, it's not necessarily like that. And many patients, when you explain them, they said, what about the recurrence? If there is a recurrence, what will happen? Will it be possible to detect? And some other family issues like children are small, there is an, right now I cannot do it. Some other issues are there. So they may not be willing for reconstruction. So, but mainly even if the lady wants, sometimes the family data is now I mean, still in our culture, that now your marriage is done, you have children, why do you want to undergo this? That attitude is slowly changing. So to change this attitude, to create the awareness that about the reconstruction, what we did was we made a lot of presentations, lectures for students, staff nurses, social workers, because in our own hospital, many times people are not aware that this is possible. Then free lectures for general public, breast support groups, patient information booklets, leaflets, interviews, workshops, articles in papers, TV interviews. And very convincing is the involve a patient who has undergone a reconstruction in your patient counseling, because that's the best ambassador for the reconstruction, who is happy with the reconstruction. So I think this is a breast cancer awareness month, and I think we should have a breast reconstruction awareness day also along with that. So breast reconstruction and oncoplasty are safe. I mean, the fear that recurrence is there, whether you will be able to detect the recurrence behind. The reconstruction does not come in way of detecting recurrence. With the newer modality of imaging, MRI and mammography, it is always possible to detect recurrence. And anytime a patient comes, whenever she makes the first visit, I think patient should be involved in the decision making from the start. And there has to be good coordination between the oncosurgeon and a reconstructive surgeon, and patient should be involved in the decision making from beginning, because they do need some time to think over. You just cannot say we'll do reconstruction, this is there, and take the patient next. They need some time to digest that information and come to the conclusion. Now, previously it was not covered under insurance, but breast reconstruction, if it's done simultaneously along with the cancer surgery, it is covered under insurance. And we have always seen that patients who have undergone reconstruction are very happy and satisfied. Patients should be educated that it is possible to do reconstruction even after many years. We had one patient whom we did reconstruction after 10 years. And then she was so happy that she used to counsel patients that get a reconstruction done. And that used to many times convince the patient that there is no morbidity, there is no problem, we can undergo reconstruction. So every woman undergoing surgery for breast cancer has a right to be informed and right to have a best possible reconstruction available and a free will to choose from. It is the primary treating doctors, I think I should say that's the responsibility to educate the patient about the reconstruction. No decision is right or wrong. Patient doesn't want a reconstruction, that also is right, and patient doesn't want reconstruction, that also is right, because it is a purely cosmetic procedure. How the lady gives importance to her body image, it depends, changes from person to person. But it should be an informed decision, not a forced decision or not any ignorance taken decision. I think each lady deserves it, and no lady should be reminded every day looking at her. You can we give them all option from reconstruction to no reconstruction at all. Patient can use an brassiere with an mold inside, and once they wear the cloth, you can't make out whether the breast has been removed or not. It is for patient's own satisfaction that it will be there. But now in today's era of tissue engineering everything and lipofilling and liposuction, maybe the thing is moving towards and tissue engineered breast or only lipofilling is possible. Thank you. These are few of the patients who are happy and satisfied, and that is how I think all patients who are coming for breast surgery should be offered reconstruction, and that awareness we need to spread it throughout. Thank you. I am willing to take any questions or answers if you have.
Yes, ma'am, there is a question, I guess.
Yes.
Is breast implant tolerated well? Any incident of rejection?
Breast implant is a foreign material to the body. if patient is likely to receive radiation, then permanent implant is not advised. Then we put an expander, which at the time of radiation, we reduce it. And then once the radiation is over, we again expand it and put an permanent implant. If patient is going to receive radiation, any foreign body we put in the foreign tissue, we put it, foreign body goes in the body usually develops a capsule around it. So if your radiation received, that capsule becomes tight and it is very uncomfortable and unnatural breast. It is tolerated by the body, but may stay for 15-20 years also. But by chance, if it gets infected or something, the body says it's not my tissue. It is not my tissue. You remove it, then only I will heal. So that is one thing that you need to explain the patient. If it is bilateral, it is usually symmetrical fall you get. But one side normal breast and the other side implant, the falls are different with the breast with an implant inside. And implants are available, different sizes. It's possible, it is patient's choice. Many times implants are used when you are doing, and if patient doesn't want any scar anywhere. In a prophylactic mastectomies where the skin is preserved completely. Does that answer the question?
No.
It's a long term, it is possible, but with its own complications if it gets infected or if radiation is required.
Thank you very much, Dr. Pradayada, madam. It was always, we can see how miraculous results a plastic surgeon can give to any procedure, and particularly in breast cancer surgery. Thank you very much, madam.
Thank you.
And now we move on to the next speaker, and that is Pritam Kumar Jain. Dr. Pritam Kumar Jain is a medical oncologist and hemato-oncologist. He is attached to a number of hospitals, including Bombay Hospital, Wockhardt Hospital, Fortis Cecil Raj Hospital, Bhatia Hospital, Global Hospital, Masina Hospital, KJ Somaya, and MP City Hospital. He has his own oncological daycare center, Jain Onco World at Mahalakshmi, Mumbai. A graduate from Pondicherry University, Dr. Jain completed his MD from BJ Medical College, Pune, followed by DM Oncology from Gujarat Cancer and Research Institute. He is an expert in treating with chemotherapy, targeted therapy, immunotherapy, and hormonal therapy. He has a skillful knowledge and inimitable proficiency in treating blood cancers like leukemia, lymphoma, and multiple myeloma. He is also endowed in treating breast cancers, colorectal cancers, lung cancers, sarcomas, gynecological cancers like CA ovary, CA uterus, pancreatobiliary cancers, kidney cancers, etc. He is actively involved in conducting many campaigns with youngsters in promoting early diagnosis and screening of cancers. I request Dr. Pritam Kumar Jain to begin his presentation. Thank you.
Yes, thank you, Dr. Anil. Thank you very much. At the outset, I would like to thank IMA for giving me this opportunity on this Sunday morning academic feast. So the purpose of today's talk is that we are celebrating October as the Breast Cancer Awareness Month. Hence, it's important, India being a developed country where a lot of cases seen in advanced stages, a lot of cancers in the youngsters also. So it's important to keep ourselves updated how best we can solve this problem in our country. So let's have a brief outline and updates on the breast cancer. So can I have my first slide, sir?
So friends, by the time Dr. Pritam comes on his presentation, we'll start with the next topic, and that is thyroid nodule. And I'll just introduce Dr. Nikhilesh Borkar. Dr. Nikhilesh Borkar has got almost 3 to 4 lines of his designations. He's oncosurgeon at Sir H.N. Reliance Foundation Hospital and Research Center. He's a consultant surgeon with the Division of Surgical Oncology. He's an expert in both breast surgery as well as head and neck surgery. He completed MBBS from Sir GS Medical College and KM Hospital and MS General Surgery from TN Medical College, Mumbai, when he stood second in MUHS. He then did his MCS Surgical Oncology from Tata Memorial Hospital, Mumbai. He then completed a 2-year Gold Fellowship in Head and Neck Surgery by IFHNOS and MSKCC, New York, USA. He was further trained in breast surgery and advanced oncoplastic techniques at Addenbrooke's Hospital, Cambridge, UK. He has been conferred with many fellowships like Fellow of American College of Surgery, Fellow of International College of Surgery, FAIS, FMAS, and FIAGES, and MNAMS. He is a member of many national and international cancer organizations like ESSO, IASO, ISO, ABSI, FHNO, ABS, etc. His special interests are surgery of head and neck, including head and neck cancers with reconstruction, larynx, parotid, thyroid, parathyroid tumors, breast surgery with advanced oncoplastic techniques, therapeutic reduction, mammoplasties and mastopexis, pre-pectoral and subpectoral implants with ADM. Today, sir will be talking on a very important topic as far as family physicians are concerned, and that is thyroid nodule. Over to Dr. Nikhilesh Bodkar, sir.
Thank you, Awad sir, for the introduction. I would like to thank IMA, all its members, and Sujata madam for inviting me here for the lecture. So everyone is aware about thyroid. It is a butterfly-shaped gland, endocrine gland, normally located in the front, lower part of the neck. Close relations to the trachea, parathyroid's recurrent and external laryngeal nerves make the surgery of the thyroid a challenging one, and someone who is not used to doing it regularly should not attempt. The thyroid job as a function is to make the thyroid hormone, which is secreted into the blood and carried to every tissue in the body. Thyroid hormone helps the body to use the energy, stay warm, keep the brain, heart, muscles, and other organs working as they should. So what are thyroid nodules? So they are solid or fluid-filled lumps that form within the thyroid. Patient is often unaware of the thyroid nodule until their family physician or any ENT surgeon or a general surgeon sees them and discovers it during the medical exam. Some thyroid nodules, however, may enlarge in size enough to make them visible to the patient or some of his relatives and make it difficult to swallow or breathe. The treatment options depend on the cause of the thyroid nodule. Around 30% of the adult women will have nodules detectable by ultrasound. In fact, diagnosis of a thyroid nodule is the most common endocrine problem which is faced all over the world. So we don't recommend doing a screening like we do mammography in breast cancer. We don't recommend ultrasound to screen the thyroid nodules. We'll come to that later. Although the majority of thyroid nodules are benign, about 10% do contain cancer. So what are the main causes we will go through? First is iodine deficiency, but nowadays iodine deficiency due to the iodized salt program of the government, it is not seen in most of the parts unless someone is from a very rural area where they don't have access to iodized salt. Overgrowth of normal thyroid tissue, what we call it as a thyroid adenoma. The cause isn't clear. It is non-cancerous and generally isn't a serious condition until bothersome symptoms from the size occur. Whereby it can compress on the trachea, which can compress the esophagus behind. And also sometimes it may, or a hyperfunctioning multiple nodes, which cause hyperthyroidism. A thyroid cyst, these result from degenerating thyroid adenomas. They are fluid-filled cavities which occur inside the thyroid. They are usually benign, but occasionally the solid component of the cyst may contain some cancer. Sometimes chronic inflammation of the thyroid is seen due to Hashimoto's disease, which is the most common cause of autoimmune thyroiditis, and causes inflammation and nodular enlargement. These are some of the hardest non-cancerous lesions which we see, and they are very stuck to the surrounding tissue, and usually associated with hyperthyroidism. The other inflammation are dequeverance thyroiditis, what we know, which is a result of viral infection. And rarely acute inflammation or pus formation occurs in thyroid because of the good vascularity and no connection to any airway or any other organ through which infection can occur. Multinodular goiter. Goiter is the term used to describe any enlargement of thyroid gland which can be caused by iodine deficiency or thyroid disorder. A multinodular goiter contains multiple distinct nodules within the goiter, which is one of the most common cause of enlarged thyroid. And lastly, the thyroid cancer. Although the chances that nodule is malignant are small, certain factors increase your risk of thyroid cancer, such as family history of thyroid cancer or endocrine cancers. Other risk factors including being young or less than 30 or more than 55, 60 years, being male, history of radiation exposure, especially previously for Hodgkin's lymphoma, radiation used to be given, the mantle field radiation, or for acne. These are sub-therapeutic radiation. It's not that they will not burn the thyroid tissue completely, and the partially burnt tissue will give rise to cancers in the future. Also, if a nodule is large or hard and causes pain or discomfort, it is more worrisome that it may contain malignancy. Just to enumerate, the benign most common are MNG, Hashimoto's, cyst adenoma, Hurthle cell adenomas, and in malignancy, the main 4 types: papillary, follicular, medullary anaplastic, and thyroid lymphoma, or rarely metastatic cancer. So high chances of malignancy in children, adults less than 30 years or more than 55-60 years, history of head and neck irradiation, and family history of. So it can cause problem in swallowing or breathing. First to get compressed is the esophagus because it is a muscular tube. Trachea is a cartilaginous tube, so it doesn't get easily compressed, but sometimes the cancer can erode into the trachea. Hyperthyroidism can occur, but it is rare in cancer. It is usually in the adenomas, which can become hyperfunctional, which can lead to weight loss, muscle weakness, heat tolerance, and anxiousness. Potential higher complications can include atrial fibrillation, osteoporosis, and thyrotoxic crisis. The problems with thyroid cancer is usually that it requires surgery and complete removal of thyroid in most of the cases, and replacement with thyroid hormone, which is a very cheap tablet which is available. So when a patient comes to you with a thyroid swelling, the points to remember are that vast majority of nodules are asymptomatic, but presence of symptoms does not rule out a malignant lesion. The risk of malignancy in a palpable or non-palpable nodule remains the same depending upon the size of the nodule rather than whether it was palpable or not. The risk of malignancy is similar in solitary or multinodular goiter. Previously, it was thought that MNG will not get converted to cancer, but various studies have proven that the risk in both is about almost 10 to 15% chance of developing malignancy in future. And do not miss the following points in history: family history, previous neck disease or treatment, hoarseness, dysphonia, dysphagia or dyspnea, location, number, growth and size of the node. One point to remember is thyroid cancers are usually slow growing. So if there is a sudden increase in the size of the nodule, it's usually due to some sort of bleeding within the nodule rather than malignancy occurring. So the diagnosis, the tests include: main is the physical examination. Ask the patient to swallow while examining the thyroid, because the nodule with your thyroid gland will usually move up and down during swallowing, but not with tongue protrusion, which can be seen in thyroglossal cyst. Look for signs and symptoms of hyperthyroidism like tremor, overactive reflexes, irregular heartbeats, or hypothyroidism like slow heartbeat, dry skin, and facial swelling. The thyroid function test has to be done. The main is to do the TSH, and then depending on the TSH finding, we may advise for free T4 or T3 levels also. Next we have to do is the ultrasonography, which is the imaging technique of choice over the CT scan also, because normally people do CT scan for other cancers or anything, but here we don't prefer unless there is retrosternal extension or overt invasion clinically. Because the iodinated contrast which is given in CT is retained by the thyroid, and then the radioiodine therapy which we give afterwards will be hampered. So we have to wait for at least 6 weeks if we do a CT scan. So ultrasonography is the imaging technique of choice used to distinguish mainly the cyst from the solid nodule and also determine if multiple nodules are present. It can be used as a guide to performing the fine needle aspiration biopsy. So fine needle aspiration biopsy or cytology. FNAB we call it when the negative pressure on the syringe is applied, and cytology when only the needle with or without the syringe attached with no suction applied is used to take tissues. Core biopsy is usually avoided in the thyroid, which is very commonly done in the breast cancer nowadays instead of FNAC. We have almost replaced FNAC. I have not done a FNAC of breast in last, I think, 10 years. But core biopsy is usually avoided in thyroid because it is very vascular and high chances of bleeding. Only if FNAC is inconclusive or on FNAC if lymphoma is suspected, then we advise for a core biopsy. The bleeding chances are small, but it can lead to significant pressure on the airway. That's why we avoid it. The chances are just about 3 to 4% across different studies. When Korea study did a core biopsy, the chances of getting diagnosis is high, but bleeding complications are there. That's why we don't prefer it. Now, how USG helps in selecting the nodules for FNAC? They may be hypoechoic, microcal, twinkling, central vascularity, irregular margins, incomplete halo, the nodule which is taller than wide, and documented enlargement of nodule more than 2 mm in a year. These are the USG features suggestive of increased risk of cancer. And low cancer if hyperechoic nodule or isoechoic, large holes, calcification except medullary. If there is peripheral vascularity, resembles a puff or a Napoleon pastry, as we say, or if spongiform appearance or comet tail shadowing is present. There are ATA, that is the American Thyroid Association, and the American College of Radiologists criteria. The ATA guidelines are easier rather than the ACR. So in ATA, any nodule which is less than 5 mm but subcapsular location adjacent to the trachea or recurrent laryngeal nerve, that it will advance and make it like an advanced stage cancer. There we advise FNAC. If there is extrathyroidal extension seen on the ultrasound, if there is extrusion through the lymph calcification or abnormal cervical nodes are already present, then we advise FNAC of the nodule less than 1 centimeter. More than 1 centimeter if it is solid and hypoechoic with one of the following features: irregular margins, microcal, taller than wide, or rim calcification with extrusion. Any nodule more than 1.5 to 2 centimeter if it is hypo or hyperechoic or isoechoic with partially cystic nodules, and more than 2 centimeter is spongiform nodules, but they may be observed also by some. Purely cystic nodules are not biopsy because they will never find, you will never find any cancer in those. There is also the ACR TIRADS grading, which many times you will find on the USG report. So on USG report, if they say TIRADS 3 and size is more than 2.5 centimeter, you should FNA them. If TIRADS 4, then size is more than 1.5, you should FNA them. And if TIRADS 5, more than 10 millimeter also, you should FNA them. So this is just the tabulated format of the ATA guidelines of when to do the FNAC. Next is the thyroid scan. Usually in cancer, we don't do a thyroid scan. It is done only when you find a TSH test which is showing suppression. So that means hyperthyroidism is there. When a radioactive iodine scan is done, it is injected into the vein and then the patient's gamma camera images are taken. Those nodules that produce excess hormones are called thyroid nodules because iodine is taken up by the scan. There is another thyroid scan, what we call it as technetium 99, which just goes into the blood vessels, and those hot nodules may be cancerous because cancer sometimes has increased vascularity. But if you do the thyroid scan, because they are non-functional nodules, they will be cold on the iodine scan, but hot on the technetium scan. Cold nodules are non-functioning, appear as defects or holes in the scan. Hot nodules are almost always non-cancerous, but a few cold nodules can be cancerous. The disadvantage of the thyroid scan is it can't distinguish between malignant and benign nodules. The length of the thyroid scan varies depending on how long it takes for the isotope to reach the thyroid gland. To summarize, what you will do is initial evaluation of all patients with thyroid nodule, which may be discovered on palpation by the patient or incidentally noted, what we call it as incidentalomas nowadays, on radiological procedure like a carotid ultrasound, neck CT or a PET scan done for some other purpose. So a detailed history should be taken with physical examination, and a neck ultrasonography should be done, and you should order a thyroid stimulating hormone. A thyroid scintigraphy or the iodine 131 scan should be performed only in patients who have hyperthyroidism suggested by low TSH. FNAB is the most accurate method for evaluating thyroid nodules, and selecting patients for thyroid surgery can be done depending if they are not hyperthyroid. One question is there when we should do a FNAC. Usually you should do FNAC of every thyroid under an ultrasound guidance. You should not attempt a direct FNAC of the thyroid. Especially if it's a node or a breast or anything, we can do a direct FNAC. But in thyroid, because of vascularity and chances of missing on FNAC, already the sensitivity of FNAC is less compared to core biopsy. And over that, if we are doing FNACs of the nodules, you may hit just the cystic part, which may not show any blood. So it's better to direct it through the ultrasound. So FNAB of the following, just to remember instead of the guidelines, that palpable incidentally detected solid nodules, if they are hypoechoic, more than 1 centimeter should be FNAC. Solid iso or hyperechoic nodules on ultrasound, if more than 1 to 1.5 centimeter should be FNA. Mixed solid cystic nodule with suspicious ultrasound characteristic. If more than 1.5 to 2 centimeter, should also be FNA. The mixed solid nodules, solid cystic nodules with no suspicious features of more than 2 centimeters should also have a FNAC. Spongiform nodules more than 2 centimeters may be evaluated by FNAC or kept on observation because they are most likely due to multinodular goiter. And in sub-centimeter nodules, only if high suspicious features on ultrasound are there, then we should FNA. When we follow up, the sub-centimeter suspicious nodules should be followed up every 6 to 12 monthly, not for every 3 months or 6 months that we advise, but sometimes the patients force us to do it every 3 monthly, so we do it. And nodules with low to intermediate suspicion should be every 1 to 2 years, and very low suspicion should be every 2 to 3 years. Another question was, is there any blood test? So the blood test which is done is usually the thyroglobulin level, which is done in the differentiated thyroid cancer. So thyroglobulin level is usually elevated in everyone. Normally it will be around 70 to 80 in all of us because it is secreted by the normal thyroid. Once you do a total thyroidectomy, it falls to less than 2 units. That time we can use it to follow up whether the recurrence of thyroid is there. Or sometimes if we do just when we are suspecting metastasis based on clinical, for example, I saw a patient who came with X-ray suggestive of multiple metastasis and we found thyroid enlarged. So there we read the thyroglobulin level and there it is elevated to more than 1000. That is suggestive of malignancy, but routinely we don't recommend doing a thyroglobulin level. Other cancer is medullary cancer, where we can do the blood test of calcitonin level and CEA level, which is to be done pre-op if we can detect those cancers beforehand, and they will be elevated. So just to summarize the diagnostic pathway, patient comes with thyroid nodule, you should do the TSH and thyroid ultrasound. If TSH is subnormal, that is hyperthyroidism, then patient undergoes a radionucleotide thyroid scan. So once we have the FNAC result, Bethesda classification gives 6, that is 1, 2, 3, 4, 5, 6. 1 is where it is indeterminate. 2 is benign. 3 and 4 is indeterminate nodule, which is Bethesda 3 and 4. 4 is follicular. They can't distinguish on FNAC whether it's a cancer or follicular cancer or a follicular adenoma, because they need the whole capsule to be examined and the whole nodule to be examined for vascular invasion. If the nodule is cancerous, suspicious for cancer, then it is given as Bethesda 5. If it is proven cancer, then they give it as Bethesda 6. Then there is molecular diagnostic test, because the FNAC cannot distinguish. So there is rule in and rule out test, where we examine the DNAs or the mRNAs of thyroid or nodule FNAC, and they are still being developed. This is especially for those indeterminate Bethesda 3 and 4 tests. The specialized tests done on samples can be obtained during the normal FNAB process, or you can do a repeat FNAC and test them. But they are not currently available at all centers, and the cost is an issue. They cost, I think, more than ₹1 lakh. So if not available, then we can repeat FNAC after 6 to 12 weeks. If still indeterminate, then the patient can undergo a diagnostic lobectomy. So this is just a flowchart showing what to do if it is Bethesda 3 or 4. That is FNA results say atypical findings or a follicular neoplasm. And if it was sample was collected for molecular testing at the time and patient is affording, we can do the molecular analysis using the gene assays or the mRNA assays. If the patient is non-affording, then we just repeat a ultrasound after say 6 to 8 weeks, and if the patient is if it is still indeterminate, then the patient can undergo diagnostic surgery at the same time, which is usually thyroid lobectomy. Now, thyroid cancer, the most common thyroid cancer is papillary, which is seen in 85% of the patients, with cure rate of almost 99% for early stage and 90% overall survival. Follicular is the second most common. Third most common is medullary, but the cure rates are not as high as the above two. The other are poorly differentiated and anaplastic. Anaplastic being the worst known cancer to humans. Hardly any survival in those. So if we go through the TNM staging, mainly we are interested in about why TNM. So the TNM staging is for survival. So in the next slide, as you can see, the disease specific survival of 10 years in those who are age less than 55. Before it was taken as less than 45. Now in the AJCC 8th edition, they have taken 55 as the criteria. So anyone without metastasis will survive. 98 to 100% patients will survive. And even those with metastasis, if you are younger than 55 years, almost 85 to 95 patients of thyroid differentiated cancer will be surviving at 10 years. The same you compare to more than 55 years, then okay. If you are not locally advanced and very few nodes, then almost 80 to 98% patients will be surviving. But if it is a locally advanced cancer or if metastatic cancer, then the survival falls down. While if you take the medullary cancer, then the survival is slightly less than this. If you go to anaplastic, then all anaplastic stage 4, irrespective of whether they are T1 or T2. T1 is less than 2 centimeter, but still it is stage 4 because the prognosis is bad. Next, we go to the 88 stratification. This is for the risk of recurrence. So what is the chances of recurrence and retreatment? Because that affects the quality of life for the patient. So these are the 88 criteria which are given, which are stage report, whether the risk is low, whether the risk is high. So obviously low risk are not given radioiodine therapy. Those with high risk are advised for radioiodine therapy, and intermediate risk is where it becomes dicey. So nowadays, so this is the risk pattern. So how the incidence of recurrence starts increasing. For example, if it's a unifocal thyroid cancer, microcarcinoma of papillary, then the chances of recurrence is just 1 to 2%. While if it is an extensive follicular thyroid carcinoma with vascular invasion, then the chances of recurrence are almost 30 to 55%. But what is dynamic risk stratification? So this is where even after the surgery, suppose the patient has undergone lobectomy, then you can assess the response afterwards also, whether the patient is biochemically incompletely response is there or structural incomplete response. So you do a thyroglobulin level even in a lobectomy patients for once or twice, keep the TSH suppressed, do the imaging and then follow up. Even in total thyroidectomy, if you want, the patient wants to avoid radioiodine, then you can monitor them and see whether the response is complete. You may not give the radioiodine immediately. You may watch the patient for say 6 weeks, 3 months, 6 months, and then decide if the thyroglobulin is rising or anything seen on the imaging, then you may consider for radioiodine therapy. So this is the new thing which is coming up. Then the surgery, usually as we said, it is lobectomy or hemithyroidectomy where we remove the isthmus, or total thyroidectomy, depending on the size of the tumor. Very small cancers can be treated with hemithyroidectomy, or microcarcinomas can be observed also nowadays. The spread of tumor to surrounding areas like extrathyroid are positive, then it is better to do a total thyroidectomy upfront. Also after surgery, if it's a total thyroidectomy, most of the patients will require thyroid hormone replacement lifelong. But it's a hemithyroidectomy, then around 25 to 30% may still require thyroid hormone. Small doses albeit. So according to the ATA risk stratification, we treat the cancer and radioactive iodine may be used. Sometimes if we do a lobectomy and final the ATA risk is high, then we may need to do a completion surgery afterwards. Or sometimes if we are doing a diagnostic lobectomy and we don't know whether it's a adenoma or carcinoma, then also we may need to go in again, which is usually either within 7 days or after 6 to 12 weeks of the surgery. In between, we don't operate because the chances of damaging the parathyroids and opposite nerve are very high. So just to summarize, less than 1 centimeter, no extrathyroidal extension, no nodes. We do a hemi unless there is cancer on opposite side, family history or abnormal imaging. 1 to 4 centimeters, no extrathyroidal extension, no nodes. Usually total is done if it's a patient preference, nodules in opposite or non-specific nodes making follow-up difficult. Then otherwise we can do a hemi also. More than 4 centimeters with extrathyroidal extension or meds to the node or distant, usually total is preferred. If any head neck radiation, usually in childhood, it takes almost 10 to 15 years for patients to develop thyroid cancer after radiation. It does not develop in like 1 year, 2 years. Then total is preferred. If papillary microcarcinoma, multifocal are found, usually in the specimen done for hemi, then no need for completion if it is less than 5. But if it is more than 5 in number, especially if 8 to 9 millimeter nodules, microcarcinoma is where it is less than 1 centimeter. But almost 8 to 9, then we would prefer to do a completion thyroidectomy. Radioactive iodine therapy, this is given after the surgery. Most of the differentiated thyroid cancers will absorb. Mind you, The poorly differentiated don't absorb. Sometimes the Hurthal cell cancers don't absorb as well. Only 30% will absorb. Anaplastic will not absorb any radioiodine therapy. So they are used to destroy. Sometimes residual thyroid tissue is left. Someone may have done a near total completion thyroidectomy. So if you have done a near total thyroidectomy, small tissue is left in the TO group, then you don't need to go back again and remove that. If the patient is high risk, you can just give a higher dose of radioactive iodine, remnant ablation as we call it, and destroy that. Sometimes we are suspecting as adjuvant due to the high risk features, then you give it to just destroy the cells wherever they are present. That's why we don't need chemotherapy or radiation in thyroid cancer, because the radioactive iodine can go anywhere in the body. And those who receive the higher doses of radioactive iodine, sometimes the salivary glands also absorb and cause inflammation and some dryness of the mouth. But it is a very minor complication. But if higher doses are necessary, there is a small risk of developing other cancers. But compared to the benefits, the risk is very small, and so we don't avoid for that. And the potential risk of the treatment can be minimized by the smallest dose. Dosimetry calculation is what the nuclear medicine guys do. And then they calculate the exact dose. If the dose is very low, then the patient goes home the same day. Otherwise, they have to be isolated for 2 to 3 days. So the patient's thyroid stimulating hormone level needs to be elevated. So after a total thyroidectomy, the patient will not be given replacement of TSH. This will be stopped for 3 to 6 weeks if they are already started. And the doctor, some people prescribe T3 if they feel the patient won't tolerate hypothyroidism very well, and that has to be stopped for at least 2 weeks. Or some people whose TSH does not rise, for example, pituitary apoplexy or pituitary hypothalamic axis is not functional, or patients with cardiac or pulmonary complications who won't tolerate hypothyroidism, then we have the recombinant TSH. 2 injections subcutaneous can be given, but the cost is high. It's almost 18,000 to 1 lakh the cost for that. And low iodine diet for 2 weeks needs to be given, because the patient's thyroid cells have to be made hungry for the iodine. As you have left a large amount of thyroid tissue, then that will take up most of the iodine which we give. So that is the requisite, that a completion thyroidectomy should be good. Dose up to 30 millicurie, then the patient can be kept in daycare and discharged the same day. If more dose, then usually for 2 to 3 days admission is needed. So the treatment summary is suspicious nodule on FNAC, less than 1 centimeter, usually lobectomy is done. If low risk, then no need for RI. 1 to 4 centimeter lobectomy or thyroidectomy may be done after discussion with the patient. If low risk on final report, not routinely to give radioiodine. If intermediate risk, then may consider or may put the patient on dynamic risk stratification. If it is more than 4 centimeter, evidence of lymph node or distal metastasis, then a total thyroidectomy with lymph node dissection is to be done and RI therapy is to be given. Other treatments, external radiation may be given for if there is a R plus resection or if there is a lot of residual. It will just slow down the progression of the disease. A few new chemotherapy agents, and mainly it's a targeted therapy in differentiated thyroid cancer, which is choice is lenvatinib. Also sorafenib may be used, which are both TKI inhibitors. The follow examination and neck ultrasound. Thyroglobulin level is the one which is used for follow-up after thyroidectomy. Some patients have anti-thyroglobulin antibodies, which make thyroglobulin undetectable. That's why the first time the thyroglobulin as well as anti-thyroglobulin antibody will be measured. Mainly patients with Hashimoto's thyroiditis or other autoimmune disorders may have this. The TSH, more advanced cancers require higher doses of L-toxin to suppress the TSH level, because thyroid stimulating hormone stimulates not only the normal thyroid cells but also the cancer cells. But if it's a low risk cancer, then TSH is kept in normal rate because the effect is not so prominent. So if you have had a radioiodine scan, or if you are intermediate risk, sometimes you may be asked to do a whole body radioiodine scan, diagnostic scan again for high risk patients as a follow-up. The PET scan, usually people advise for looking for metastasis early on, but in thyroid cancers, we usually don't do. It is usually done if thyroglobulin is elevated on follow-up and negative iodine scan is present. Tennis syndrome, as we call it. That is the only indication where we do PET scan on follow-up. A little about medullary cancer. It is a rare cancer arising from parafollicular, the neural crest cells. rise in calcitonin and CA levels can be seen. Surgery is usually total thyroidectomy with central compartment clearance, sometimes lateral neck too. No role of radioiodine therapy or TSH suppression in these. EBRT if residual or R plus resection. Vandetanib is given for metastatic or advanced inoperable medullary cancer, which is again a targeted therapy. So the take-home message is thyroid nodules generally do not cause symptoms. Thyroid tests are most typically normal even when cancer is present in the nodule. Best way to find a thyroid nodule is to make sure you check the patient's neck and do an ultrasound if needed, and don't forget the TSH level. The overall prognosis of differentiated thyroid cancer is excellent, even especially in those less than 55 years. For older than 55 years or those with larger aggressive tumors, prognosis still remains good, but the recurrence risk is higher. Advanced cancer, if they cannot be completely removed or destroyed with radioactive iodine treatment, prognosis is not good, but nonetheless, these patients continue to live for a long time, despite the fact that like a chronic disease like diabetes or hypertension rather than curing it completely. Thank you. You can email the queries to me if any further.
Oh, there are few questions. Chirag?
Okay.
Yes, sir. The first question is, what are the indication of FNAC of thyroid under USG guidance?
So usually USG guided FNAC is the rule in thyroid. Unlike a breast cancer, or if it's a node which is enlarged, then we can do a direct FNAC. But in thyroid, many times the nodules are cystic, and you need FNAC from the solid component, and the solid component may be small. Unless it's a very large thyroid, then you may take a chance, like a poorly differentiated large 15 centimeter nodule is there. But sometimes that may not show cancer, but other nodule may be suspicious. So it is always better to do a USG guided FNAC, and the cost of USG guided FNAC is not much. It will be around 4,000 to 5,000 rupees even in our hospital, and most of the other centers will be the same, I think, including the cost of the pathologist. That's why. So I would prefer the USG guided FNAC over a direct FNAC.
The other question is, any blood test we can suspect thyroid cancer?
In medullary thyroid cancers, we have the CA and the calcitonin levels. But for papillary thyroid cancer, thyroglobulin is usually advised post-op. It is not advised in the pre-op unless you are already suspecting metastasis clinically. We don't do a metastatic workup in thyroid cancer. We usually operate the patient first if it is cancer, and then if high-risk features are there, then we advise a radioiodine scan. But if you are suspecting anaplastic cancer or a poorly differentiated, then you may advise. But blood test only CA and calcitonin or thyroglobulin, if it is elevated to thousands, then it is suggestive of metastasis. But usually we don't advise a thyroglobulin level pre-op.
We got one more question, sir. Can you comment on Hurthal cell carcinoma?
Hurthal cell, there are 4 variants which are usually said as poor variants of the papillary. One is the Hurthal cell carcinoma, other is the Hobnail variant, tall cell and the columnar cells. These all 4 variants make it an intermediate risk, ATA risk of recurrence. So the prognosis still remains good, but they may require radioiodine therapy. The problem with specifically the Hurthal cell is the radioiodine uptake is not seen in all the cells. About 25 to 30% of Hurthal cell carcinomas will have radioactive IVDT, and they may not, the others may not take up radioiodine so avidly. So, but sometimes we try higher dose of radioactive iodine to cure that, because sometimes that high option in Hurthal cell carcinoma. Many times there is minimally invasive Hurthal cell carcinoma. If it is minimally invasive, then the prognosis still remains good, and we don't advise radioactive iodine therapy for those.
Right, sir. We are done with the questions.
Yeah.
Thank you.
Thank you very much, sir. Your experience and expertise is so vast that we would love to hear you again on IMA platform.
Thank you, sir. Basically, my topic was supposed to be breast cancer, but on request, I took on thyroid.
Yes.
Anyways, and for breast, I
we
would advise.
Definitely love to hear you, sir.
For breast, one advice I would give, because people come with only ultrasound and FNAC. So I would advise above 40, you can do a 35 to 40 years. Please do a mammogram. And I would advise a biopsy, core biopsy, not a excision biopsy, not a FNAC, because that gives us more information. Because many times they come with a core FNAC and I have to again do a core biopsy. Even in early cancers, I would advise that.
Yeah.
So I think Pritam should cover that.
but just in case. Okay. Thank you, sir.
Thank you, sir. So we move on to Dr. Preetham. I hope the presentation is ready. Chirag, we have already introduced Dr. Preetham Kumar.
Yes, sir. The presentation is ready and we are ready to present.
Okay.
So just want Dr.
Before
Preetham, sir.
we start with the lecture, I want to make one announcement to the delegates. In spite of repeated telling, the delegates are logging on with their own mobile name. I have got many names like 1+5, 1+6, 1+ North, Galaxy, J7. So it is very difficult for us, to give the list to the MMC. So please log in with your own name. We have people logging with VR, AJ. I mean, how we'll find out, no, who is that person? So please log in with your own name. Okay. And now we go on to Dr. Preetham Kumar Jain.
Yes. Good morning, everybody. Am I audible and visible?
Yes, sir. Yes, sir. Yes, sir.
Perfect. Thank you very much. So I'm back. Thank you for the patience, and you've been waiting. All right. So let's begin with something about breast cancer, from thyroid to breast. I've been listening to Dr. Nikhil sir also, and so October month is, we generally celebrate as Breast Cancer Awareness Month, and it's important because this is the leading cause of cancer deaths amongst women, and also one of the commonest cancers in women. So what is important in this is, if you quit, you lose. If you fight, you survive. So you have to be a fighter, not a quitter, when it comes about breast cancer. Okay, so let's begin with this very important fact. Where does India stands? Okay, if you see, 1 in every 22 women is suffering from breast cancer in India. So this is the reality in India. If you compare this Indian statistics in comparison with the US statistics, in US, 1 in every 8 women is suffering from breast cancer in US. So the frequency is more over there as compared to India, but the mortality is high in India for multiple reasons, which I'll be discussing. So the fact is that 1 in every 22 women is suffering from breast cancer in India. So it's important you detect this cancer at an early stage, and this is going to save the life. And that's the reason why today we are here. And let's see what are the other statistics that says. Next slide, sir. So it's the pink ribbon. Commonly, we represent this breast cancer awareness. So we are celebrating this October month in the form of a breast cancer awareness. Next, sir. Okay, so this is the world map. Wherever you see the pink shadows, that tells you the status of the country suffering from breast cancer. And if you compare with India, you see almost all of the Indian map is shaded with the pink, suggesting that India definitely is, it's an alarming increase in the incidence of breast cancers in India. So globally, if you see, the mortality is extremely high in India and in all these, also in the African and American countries, the mortality is there. So it's important that you try to diagnose this cancer at an early stage, because the mortality comes down very significantly, and the mortality is preventable. So this map actually tells the real scenario. Next. Next slide, sir. Okay, so the Globocon is the worldwide statistics data, which in 2018 says clearly that the breast cancers is almost number of new cases have been 1,62,468 cases. That's 14% of all the malignancies. So that's a huge number that we are seeing, and it has been predicted that by 2022 this is going to cross 2 lakhs every year. So around about more than 101.5 lakhs cases is what we are seeing in India, and that's really alarming. And one need to understand that the risk factors have been not been very well appreciated in the common society. Next slide. So the Globocon data says the breast cancer ranks #1 among all the cancer types in India, all right? So the top 5 most frequent cancers, excluding the non-melanoma skin cancers, right at the bottom, if you see that in both the sexes, males and females, in males it's lip and oral cavity, but in females it's the topmost cancer, and it is also a leading cause of mortality among the women, So this is the statistics that is alarming, and it's important that we are taking this very seriously because it's a preventable mortality. Next. Next slide. Yeah, so age-wise also, if you see the world incidence and the mortality rates, top 10 cancers, the breast cancer stands right at the top. It's 24.7 incidence and the mortality is 13.4%. Okay, which is right at the top as compared to the cervix, lip, oral, ovary, lung cancers. And that's why I'm here today to just take you to the journey of this, breast cancer patients. Next slide, please. So why all this fuss about? Because early detection of cancer actually makes a significant difference, and that is the importance of breast cancer awareness. So how do we do this early detection? Is by various screening methods also, and based on this, the mortality is prevented. Next slide. So some women in this crowd may have an early cancer. How do you detect, right? So there is a woman with the breast cancer. Still, she's been taking care of the whole family. This is a very common scenario in the whole Indian setup that, many women in India comes to us at an advanced stage. And the reason for this is that they are so busy in their household work, taking care of the family members, kids, that despite noticing a lump in the breast, they do not go to the doctor immediately, considering the fact that when we ask, why did you not come early? They said that I was busy with my family members in taking care of them. Hence, I thought it will I might be disturbing others. At the same time, a man with the flu, he takes, leave from the office and he's taking rest. But the woman with the breast cancer is still actively, taking care of the family. And that's why the women have been, they're very strong in terms of their work. And that's why it's important that we try to prevent the mortality of the Indian women and the worldwide also, because they are an important component of the family members. Next. So let's make it a pink. It's called as Pink October. Okay, so in US, it's 1 in 8. In India, it's 1 in 22. Every 2 minutes, a case of a breast cancer is diagnosed among the women. Every 13 minutes, a woman dies of breast cancer. The largest group of survivors with more than 2 million survivors is again a breast, stating the fact that if you early diagnosis, you can prevent the mortality, and these breast cancer patients survive for a very long time. And above all this, breast cancer is the most common cancer worldwide among the women. Next slide, please. Okay, here is the one, the importance of early detection, all right? You see, if the early detection means less invasive treatment, less trauma, less pain, less cost. Early stage diagnosis, you can cure the cancer. So it is important to be vigilant. In terms of the survival rates, you see, if you detect the breast cancer at an early stage, your chances of surviving is 93%. And once this patient comes to us in a later stage, your chances of survival is only 6%, all right? So in India, majority of the patients comes to us in an advanced stage because of the lack of awareness and lack of communication. And that's the point. That's the reason why we have to be very vigilant when it comes to detection of the breast cancers. Next slide. So simple anatomy, okay, breast, the cancer can originate either from the ducts or from the lobules. The breast has a fatty tissue component, and its lymphatic only goes to the axillary lymph nodes. Then you have the muscles, the chest wall, the clavicle, the nipple and the areola. All this is important from your local examination point of view, because any lump can distort this anatomy and you need to remain alert and refer it timely. Next slide. Yeah, so the major components are stroma, lobules, and ducts, and the adipose tissues. And commonly the cancer arises from these ducts and the lobules, so they are called as ductal carcinoma, and if it's arising from the lobule, it's lobular carcinoma. Next slide. Okay, so this is the most important lymphatic drainage, and depending upon these lymph nodes, common presentation is a breast lump going to the axillary lymph nodes. Hence, examination of the armpits is of paramount importance, because many a times you may not have any breast lump, but straight away axillary lymph node swelling is visible, and then you notice that there is something inside the breast. All right. So knowing these lymph nodes anatomy is of paramount importance. Commonly, the lymphatic drainage it goes to the axillary lymph node, the infraclavicular lymph nodes, the supraclavicular lymph nodes, which is just above your clavicle, and the internal mammary group of lymph nodes. This helps in staging of the breast cancers and prognosticating the breast cancers. Any breast lump with supraclavicular lymph nodes carries poor prognosis, and any patient with an armpit swelling can have a breast lump retrospectively or a breast cancer retrospectively. So a complete examination of the breast along with the axilla and the supraclavicular and the infraclavicular area will actually give you a better information of the underlying breast malignancy. Next slide. So the risk of advanced breast cancers in the developed or the underdeveloped countries, especially in India, the lack of knowledge and education. It's quite common in India, women, especially household women who are very busy in handling their, kids, the family members. Even if they have some knowledge, they don't come to us. They are not educated when to timely, meet your specialist doctors, to find out that the problem can be really serious. Poverty, local customs, okay, in India, many times, they feel shy in talking about their, breast lumps or anything abnormalities that is there in the breast, okay. These are the local customs. Not exposing themselves even to the physicians, delay in referral of the patients from the underprivileged remote areas, till disease becomes incurable. So these important factors is present in our country, and that's the reason why the mortality is very high in India. Despite having a low incidence as compared to the America, the mortality rate is extremely high in our country. Next slide. So the risk factors, there are many risk factors, okay, although not a single risk factor can be actually directly attributing to breast cancers. But what we found is that women with early menarche, late menopause, causing prolonged exposure of estrogen to the body. Then there is nulliparity, women who don't get married and they don't have kids. As a result, they do not breastfeed their kids, or lack of breastfeeding also increases significant the risk factors. The hormonal therapy also has its role because of the estrogen receptors that are present in the breast. Hysterophony radiation can also significantly cause the risk of breast cancer, especially when there is a past history of radiation to the chest wall, commonly seen in Hodgkin's lymphoma patient. And the modern lifestyle with alcohol intake, high fat diet, tobacco use, sedentary lifestyle, lack of physical activity leading to obesity. This also is leading to increase in the risk factors of breast cancers, especially in the women. So when you have a younger woman coming with the breast cancers, never forget that there might be a significant family history with a strong genetic background leading to inheritance susceptibility. Next slide, please. Right. So there are factors which are associated with decreased risk of breast cancer also, So the previous slide shows the increased risk. So what factors can actually decrease the risk? Although it may not prevent you 100%, but definitely the risk comes very significantly, right? So those are like, you see, estrogen only use among women with hysterectomy, 23% decrease incidence of the invasive breast cancers. A good amount of exercise every 4 hours, more than 4 hours, every week is associated with decreased breast risk cancer, almost by 40%. That's a huge percentage, The effect is highest in the premenopausal woman. Okay, so a premenopausal woman attributing herself with daily exercise, actually her risk factor for the breast cancer risk decreases significantly. And early pregnancy, all right. So women with a full-term pregnancy before the age 20 have 50% decrease in the breast risk as compared with the nulliparous women or those who give birth child after the 35 years of age. Breastfeeding is also protective, among the women. So those who breastfeed their children, the breast cancer decreases by 4.3% every year, in addition to 7% of each birth. So these are the factors where you can ensure that your risk factor decreases of breast cancer. However, having said this, all women above the age of 50 are at an average risk of breast cancer, irrespective of any underlying severity. Next. So the site of origin. Continue tapping. Yeah. Back, please. So the site of origin, as already mentioned, okay, commonly you see the biopsy report or the histopath report, you see either it's a ductal carcinoma or it's a lobular carcinoma. This depends upon the site. So the ductals are the one which are milk ducts, and the lobules are the milk producing lobules surrounded by connective tissues. Okay, so site of origin determines its behavior and treatment outcome. What it means to say that lobular carcinomas are more aggressive and has a bad prognosis than ductal carcinoma. Next slide, please. So the ductal carcinoma, this is the anatomy, okay? They starts in the cells which lines the breast ducts. The 85 to 90% of all the breast cancers are ductal in origin. If the ductal carcinoma is in situ or is well contained, not invasive, for example, that the tumor cells has not invaded the basement membrane, then these are 100% almost curable and very successfully can be treated. The in situ carcinomas. Next slide. The lobular carcinoma, as you can see in the diagram, they originate from the lobules, okay, which are milk production, anatomically. They are located very deep inside, hence they might not be easily palpable. And only 8% of the breast cancers are lobular. Many lobular carcinomas are bilateral in nature and they have a bad prognosis. So it's important not to miss these cancers in early stages. Next slide. The other forms of breast cancers, something called inflammatory breast cancers, where there is redness surrounding the breast. So any redness should not be ignored, okay? The skin redness, skin ulceration, even sometimes itching, eczema like kind of, appearance, okay? It might mimic like a mastitis, but actually this patient may have an underlying breast lump with a carcinoma. And if a patient presents to you which is mimicking like a mastitis, these patients may have a high chances of spreading. So never miss this. If you have any suspicious, okay, get an examination done. You can get a sonography done to rule out any underlying malignancy lump. Clearly in the picture with an initial condition, you see there is a small redness over the breast lump. After 1 month, the redness is increasing. Then in the 3 months, it's surrounding almost 50% of the breast. And by 4 months, it has actually gone, advanced and started spreading. So do not miss even any minor skin changes over the breast on examination. Next slide. So the clinical presentation, any lump in the breast, very important. Most breast cancer lumps are painless. So never wait for the pain. By the time you have pain, it means that the breast cancer has already gone into an advanced stage. And that's a problem with most of the patients in India. they think that unless there is a pain in the breast, you need not meet the doctor. And by the time they have pain, it's already gone into an advanced or locally advanced or a distant metastatic stage. The other presentation is nipple changes, discharges, crusting, nipple may get inverted, there may be change in the size or shape of the breast. All this could be the signs of malignancy, and malignancy is the biggest mimicker of all the disease. Next slide, please. Yeah, next. Okay, so just now I've told that, the screening methods is of paramount importance in actually finding out the early stage of the cancer. You see the diagram, what is saying, okay, when you screen, the average size lump found by women by practicing occasional breast examination is this size, which is visible in the pink. Okay, if you practice a regular breast self-examination, you may detect a lump at a very smaller size as compared to the occasional examiner. Okay, and as compared to the breast self-examination, if you do a mammography actually detects the lump at a much smaller in size as compared to the breast self-examination. And when you do a regular mammography, okay, like after 50 years in an average risk and after 40 years at a high risk, a regular mammography can detect the breast cancer at a very small in size, just like a dot which is visible, and that can appear in the form of a calcification, and that is a malignant a nodule, and that if you remove it, patient can get cured and there is no complex of the treatment at all. So this is the importance of screening. A regular breast self-examination and regular mammography can prevent the mortality and unnecessary treatment which is complex in nature, and can reduce the cost and burden of the family or the patient. Next slide, please. So whoever thought of the word mammogram, every time I hear it, I think I'm supposed to put my breast in an envelope and send it to someone. All right. Okay. So that's the best gift that you can give to every woman on their birthday. Okay. Just give them a reminder with the help of an envelope that you need to undergo a mammography. Okay. So they'll be more than happy. And the other side, they say, yes, I did have my mammogram today. Why do you ask? Okay, that's the reason. Anyways, okay, this is the way that we try to, create awareness among the patients and the society. Next slide. Okay, so these are the screening guidelines. I'm not going to go too much into the details of this table. In short, 40 years is the age cutoff and 50 years is also the age cutoff. Generally, what I tell to my patients is that if there is a significant family history of breast cancer, then all the women in that family should start their screening at the age of 40. Okay. And an average woman, okay, without any significant risk factors can begin their mammography even at the age of 50 as per US Preventive Special Task Force. So after 40 years, you need to remain vigilant and start thinking of mammography, especially if you have a family history of first and second generations. Get your mammography done every year. If not, at least once in 2 years can be done. But do not forget, because the size that is picked up by the mammography is of very small in size and can easily be early diagnosed and prevent further unnecessary complications. So this is what is the screening guidelines. This is different organizations have given depending upon their institutional practice. In short, above 40 years of age, mammography can be started. Above 50 for an average woman, and above 40, sometimes even 35 is considered, especially if it's a BRCA positive. Next slide. So this is the journey, breast screening and diagnostic journey, all right? So the first symptom, you notice a lump or change in your breast. If you are over the age of 40, you can schedule a mammogram even if you do not have any symptoms, or you refer it. The second journey is your doctor, okay, you schedule an appointment with the doctor to see if he or she agrees with your abnormal finding. The third is get the mammogram done. You and your doctor schedules your mammogram at whichever is the nearest center. Also, do not forget to involve a radiologist, because a simple sonography of the breast can also, help in diagnosis. If still you have a suspicious that where the screening guidelines like mammography or sonography is not picked up, MRI of the breast is also a good option to detect early breast cancers in highly selected patients. Then once you feel that there is a suspicious, you are seeing a lump, okay, you refer the patient to the specialist for the biopsy. And once they do the biopsy, the patient will be planned during the journey of the treatment, surgery, chemotherapy, and radiation therapy, depending upon the stage of the breast cancer. So this is the overall journey of a breast cancer woman, okay, right from the first symptom till the treatment. Next slide, please. So the diagnostic workup quickly, okay, the sonography is extremely important, all right, and the mammography. Generally, a combination of sonomammography is done. The problem with this is that in younger women, because of the dense breast, all right, they may not pick up the underlying small lesions and can get missed, okay, many times. So that's the limitations of this sonomammography. However, one should not differ from this particular test whenever you have any suspicious. And then when you have a lump, get a fine needle aspiration cytology of the breast lump. And if the lump is once again suspicious on FNAC, biopsy, it needs to be done. Next slide, please. All right. So once you have got a tissue biopsy suggestive of breast cancers, then it's important to describe the breast cancers, then the major discussion starts that what is the stage of the breast cancers. This is commonly determined by TNM staging. T stands for tumor size, N stands for node, M stands for metastasis. Then what is the morphology of the tumor? It is a high grade, low grade, Ki67, all these things are generally mentioned in the histopathology report. And third aspect is very, very important, is the special receptors. So if any of your patient says that I've been diagnosed with a breast cancer, the first thing that we ask is what is your immunohistochemistry receptor status, whether they are hormonal receptor positive, that is estrogen receptor and progesterone receptor. And the next important is HER2 new. So if this is positive, depending upon this, the whole treatment is planned. So ER, PR, and HER2 new is very, very essential in planning the treatment of a breast cancer patient. Next slide, please. So this is the TNM staging. Basic is like, it's between the first stage is less than 2 centimeter. The second tumor is 2 to 5 centimeter. And the third is more than 5 centimeter. If you feel that the breast wall is fixed to the chest wall, or if the skin is involved where there is ulceration, redness, erythema, inflammation, then straight away it is T4, okay, irrespective of the size, all right? Generally, any patient who presents to us with more than 5 centimeters, they are called locally advanced and there is a high risk of distant metastasis. That's why you have to understand that to diagnose this certain early breast cancers. Next slide, please. Receptor status, already mentioned, two important receptors, estrogen receptors and progesterone receptors. Why is this important? Because we have hormonal treatment, okay, which is in the form of oral and as well as injectable, which is to be planned once the surgery is done or once it is a metastatic, we try to plan this treatment. Another important is that if a breast cancer lump is HER2 new positive, then it is associated with a high possibility of invasion and metastasis because these are high grade tumors. It carries poor prognosis. So this HER2 new test is done by FISH method. And once HER2 is positive, we have targeted therapy which exclusively targets HER2 new. And then it carries a better prognosis than without treatment. Next slide. So overall, it's a multidisciplinary management of the breast cancers, right from the general physician, okay, who is doing a breast breast examination and referring it to the specialist for sonography, mammography, biopsy, histology, then surgeon doing the surgery, and then followed by we have chemotherapy, hormonal therapy, and systemic therapy in the form of a monoclonal antibody and targeted therapy, and radiation therapy if the lymph nodes are involved. All right. So this is a multidisciplinary team management, and the patient, are being, referred to all these different departments for her survival. Next slide, please. Okay. Treatment can be divided in whether the breast cancer is an early breast cancer, commonly called as EBC, whether it's a locally advanced breast cancer, or it's a metastatic breast cancer. All right. So the basic definition of the breast cancer itself has changed now. Previously, any breast lump surgery was the main line of treatment, because it was of the perception that the lump breast cancer is a disease of the breast itself. But it has changed now. The basic definition, what has changed now, that this breast cancer is a systemic disease with a local manifestation, and the local manifestation is a breast lump. So even when the breast lump is present, patient already has a micrometastasis, and that's why there is a role of multidisciplinary. So for example, if a patient has early breast cancer, the first line of treatment, which is most important, is the surgery. The moment once you have a locally advanced breast cancer, then surgery, radiation, and chemotherapy, all the options are available. In a metastatic breast cancer, there is no role of surgery. The systemic treatment is the most important treatment for her progression-free survival. So this is the main treatment outline. Many times in locally advanced, in fact, in all the cases nowadays in locally advanced breast cancer, where it is inoperable on first day, we start with chemotherapy or targeted therapy. The big size breast lump shrinks significantly. Many times the tumor disappears also, and then they are taken up for the surgery, and this gives the best line of treatment and the best survival for the patient. Next slide. Treatment options, once again, surgery, systemic, radiation therapy. The standard treatment in terms of surgery, generally it is a breast conservative surgery, or it's a lumpectomy, or it's a modified radical mastectomy. In today's scenario, the overall outcome of a breast conservative surgery and a modified radical mastectomy is almost similar. So if a young woman who desires to conserve her breast, yes, she can go ahead, because the outcome will not differ even if she removes a complete breast or reserve the breast. All right. Then radiation, chemo, hormonal, targeted therapy. Next slide. Okay, so this is the breast conservative surgery where a lump, okay, it's called lumpectomy. We preserve the breast and just remove the lump. So any breast conservative surgery is followed by radiation therapy. It is compulsory to prevent or decrease the risk of local recurrences. Even if the nodes are negative, if a patient has undergone breast conservative surgery, okay, radiation has to be given. It's mandatory. Next. This is the radical mastectomy, where you remove the entire breast, chest wall. Along with this, the lymph nodes at level 1, level 2, and sometimes more distant level of group of lymph nodes are also removed. Nowadays, we don't do radical mastectomy. It's a modified radical mastectomy. Next. Yeah, this is the modified radical mastectomy. So the entire breast is removed. Up to level 1 and level 2 axillary lymph nodes are commonly removed. So modified radical mastectomy is nothing but simple mastectomy along with axillary lymph node dissection. Next slide, please. Okay, so as mentioned, any patient after the breast conservative surgery has to undergo radiation therapy. So this is called adjuvant. Adjuvant means subjecting the treatment after the surgery. This is to ensure that the micrometastasis that is present at the breast itself to eliminate this micrometastasis after negative margin. Generally, they give the dose of the fraction depends upon the area to be irradiated. Commonly is 50 gray upwards. There's something called ABPI, which is also a preferred approach as it decreases the duration but enhances the skill rate. Next slide, please. Okay, the rationale for hormonal therapy in breast cancer. You see, the breast cancer, okay, spreads with the help of this signaling pathway that is through estrogen receptors. So what we do is we give hormonal therapy. What it does is it blocks the estrogen related cell proliferation in the breast cancer by one or the following methods. One is either you block the estrogen receptors, you downregulate the number of estrogen receptors, or you inactivate the estrogen production in the ovaries. That's why many times patients are also given the option of oophorectomy where the estrogen source is brought down. Once the estrogen source has brought down, the breast cancers does not proliferate and comes at a halt. So it does not metastasize or it causes invasion. That is the rationale for hormonal therapy in breast cancer. Next slide, please. So this is called adjuvant hormonal therapy. Adjuvant means after the surgery. If it's a premenopausal woman, we advise the patient to undergo oophorectomy because this controls the metastatic disease in a metastatic patients especially. And commonly used drug is tamoxifen. So this is the commonly used drug hormonal therapy. It's a simple oral drug which is very safe, commonly used by the patients, very safely used at home. And it's a good drug to prevent metastatic also. So this is what the hormonal adjuvant therapy we use. Next slide, please. Okay, the other drugs, okay, if it's a premenopausal, we use tamoxifen, which is given there in your in the picture. If it's a postmenopausal, after generally 48, 50 years, we suggest letrozole because it has shown to be better than tamoxifen in a postmenopausal woman. However, tamoxifen can be used both in pre and postmenopausal women. The other drugs that also are in the picture is that exemestane and anastrozole. Generally, they say that aromatase inhibitors are more effective than tamoxifen, especially in the postmenopausal woman. So this is all about hormonal therapy. These are the oral tablets. These are not chemotherapy. This is simple hormonal tablets. Next slide, please. Okay, so now coming to fourth stage of the breast cancers. This is the common presentations that we come across in our country. You can see in the picture showing redness, granulation, skin ulceration with swelling in the armpit. And when you do a scan, a PET CT scan of all this patient, clearly you see a distant metastasis going to the lungs, liver, bones, okay, in the supraclavicular lymph node. So the distant metastasis, supraclavicular lymph node clearly indicates that it's a stage 4. So any patient with a breast lump, please just simple examination of the supraclavicular area tells you the stage of the disease, and the patient should be immediately referred to the medical oncologist because it's a 4th stage disease which needs to be prevented further for metastasis. Next slide, please. Okay, so this is the systemic treatment. So if I have a patient with advanced breast cancer, these patients are under the guidance of a medical oncologist. The aim of the treatment, okay, in the form of chemotherapy, hormonal therapy, targeted therapy is eradicate the micrometastasis and form effective treatment for overt macrometastasis. So this is the outline. If it's a loco-regional disease, you go ahead with the surgery, radiation therapy. If it's a distant metastasis, find out the receptor status, whether the patient is estrogen receptor positive, HER2 positive, or HER2 negative. If the patient is estrogen receptor positive, then if the patient is not in crisis, straight away you can begin with the hormonal therapy. If simultaneously HER2 receptors are positive, then you have to start with anti-HER2 therapy, which is called as targeted therapy or monoclonal antibody. And this is an expensive treatment for a long period. A lot of counseling is required because financial burden is there, and it carries also a bad prognosis. But with the help of anti-HER2 therapy, the response is excellent in majority of the patients. provided patient takes the treatment as per the schedule. If both ER is negative, HER2 is negative, then it is called as a triple negative breast cancer. This is again a very aggressive cancer. In a triple negative breast cancer, there is no alternative but only and only chemotherapy. Recently, now immunotherapy options has been opened up, okay, because of the significant advantage in terms of their PFS. So this is the outline of a systemic treatment in an advanced breast cancer, commonly called as ABC, advanced breast cancer. Any patient with an advanced breast cancer should be referred to the medical oncologist to begin with the systemic treatment as early as possible and prevent further metastasis, thereby decreasing the progression-free survival and increasing the overall survival of the patient. Next slide, please. Perfect. So this is the systemic treatment approach in a metastatic breast cancer. In short, we call it as MBC. Whether immediately what we ask is ERPR is positive or it's negative. If ERPR is positive, HER2 is positive, start with endocrine therapy and anti-HER2 therapy. You can also add chemotherapy to this. If HER2 is negative, then it's chemotherapy and hormonal therapy. If all the three are negative, only chemotherapy. There is no alternative. Chemotherapy is lifeline for these patients. And if HER2 is positive, combination of these two can be taken into consideration with the best outcome. Next slide, please. So the challenges situation in India is the lack of awareness, poor awareness of the early indicators of breast cancers, and a lack of knowledge about how to self-examine is another important challenging situation. Suboptimal medical infrastructure. We get so many patients here who stays in the rural areas where there are no facilities. Somebody tells them that, okay, they don't refer it timely, or because of the poor infrastructure, patients are not being examined. They come to us a very straight away in the very upfront fourth stage. Urban Indian women who work start having sex later, have few children and breastfeed them less than their rural counterparts, increases the risk of breast cancers. Less availability of screening is the problem again in India. Some are reluctant to consult male doctors. Another big problem that we have this stigma that the patients are, reluctant in having being examined to the nearest male doctors, whoever is available. Low doctor-patient ratio, poor financial resources on the patient's part as well as the healthcare provider's part. Next. So because of all these challenges, we're extremely thankful that the government has come up with many initiatives, like India has launched plans for national cancer mandatory screening programs, which all of us should follow to prevent this dreadful breast cancer causing mortality. The second they have also done is that the Ministry of WCD, okay, wealth, Commonwealth diseases, health awareness programs to spread awareness of both cervical and breast cancers for the women, okay, cancer development. This initiative will not only help in early diagnosis, but will also generate awareness on the risk factors of the disease. Okay, so this is important from the government perspective also. The federal government of India has taken important policy decisions towards controlling the cancer and other non-communicable diseases, like examples, COTPA, all right, 2003 cigarettes and other tobacco product inhibition. So all these different initiatives by the government has begun with an intention to ensure that the breast cancer mortality is reducing and the incidence also does not increase. Next slide, please. Okay, so just I'm going to come to an end of my today's session. Nearly 50% of the most common cancers can be prevented. I'm not talking about just breast cancer, take any cancers, all right? 50% of the cancers can be prevented. Common cancers in India is breast, cervical, lung, and head and neck cancers. Lung cancers, most important risk factor is your smoking. So you don't smoke, you can prevent it in as much as patients, all right? Again, tobacco consumption causes both head and neck and lung cancer. You stop the tobacco consumption, your cancer will be prevented. You eat well, stay lean, no obesity, give lot of work to your legs, okay? Physical exercise. Get yourself vaccinated, okay? Protect your skin from the sunrise and do not smoke. When you follow this, 50% of your cancers can be easily prevented. Next slide, please. So just, the take-home messages are factors that can help lower the risk of breast cancer. Healthy weight, do not smoke, physical activity, no alcohol use. Next. Breast cancer preventive strategies, okay? Regular medical checkup. Please be proactive. Get an annual cancer screening done. All women after the age of 50, irrespective of what problem they're having, they are at an average risk of breast cancer. So get yourself screened done. All women after the age of 40 can also undergo breast cancer screening with mammography if they have a significant family history. Don't wait to get sick before taking action. Don't wait for the pain. Next slide, please. So summary here, we are witnessing breast cancer in a much younger ages than earlier because of the risk factors that are prevailing in the modern lifestyle. The numbers of breast cancer cases in all the age groups is rising rapidly. More than half of the patients still present to the doctors in advanced stages. Unfortunate, but this is the reality. Breast cancers in the young tends to be more aggressive. Please don't be of the notion because she's young, so she will recover. No, the younger breast cancers are more aggressive than the older population, and the survival in younger patients, especially in advanced stages, is less. So ensure that a young woman who has just become a mother, who has kids, she needs a good family attention. So I believe every husband should, okay, give a gift to their wives on the day of their anniversary. Please take her for mammography screening after the 40 years of age. That's the best gift that you can give. Next slide, please. Next slide. Yeah, please press this. Okay. Okay, this is something which I just wanted to tell you that, every year in the whole, I mean, like in the world, some prominent places are being enlightened with pink structure. So that's a Burj Khalifa, which enlightens every year on the pink. Unfortunately, in India, I've never seen some prominent places being enlightened with pink. I hope this happens every year with a dedication. The Taj should get enlightened with pink. Our Gateway of India and the Taj Hotel should also get enlightened with pink, thereby creating awareness and importance of breast cancer screening. Next slide, please. Thank you. Thank you very much for your, patiently listening to me. Now I'm ready to take up your questions.
So we have some 5-6 questions.
Yes, sir.
Just a minute. So the first question is, do CA-based present is intercostal neuralgia. So you can see it into question answers if you
Where
tap
is this?
on at the up
Yeah,
top.
I got it. Okay.
Yeah.
What's the first question?
So you can start from the third.
Okay, do CA breast patient
an
presents
intercostal.
intercostal neuralgia?
Yeah.
You see, as already mentioned, never wait for the pain. So if there is a pain, the pain will be somewhere, over the breast lump or around the surrounding the breast lump, to the chest wall fixation and the underlying ribs where there are nerves. If it's a locally advanced and invading the underlying tissue, they can have the pain at the local site. Now, whether it is an intercostal neuralgia and all, we cannot differentiate this, but definitely pain is an important symptom of an advanced cancer. If a particular nerve has been impinged there, naturally they can have neuralgia. What's the next question we have? Sir, can fibrocystic breast lump will change into carcinoma? Yes, the benign fibrocystic breast lump, okay, can can convert into malignancy, but the risk is very low, especially when there are atypical features, complex features. Okay, at that particular time, you need to have a close follow-up of the patient. It can, however, the risk is extremely low. Benign breast diseases also needs to be followed up, especially when they have a significant family history. So it is better to keep a close follow-up. All right, especially if that particular lump is increasing in size every year and the features are being atypical and complex or lobular in nature, I think changing into carcinoma is a high likely. Next question, role of monoclonal antibody is in metastatic breast cancer. The role of monoclonal antibody is very, very essential in a metastatic breast cancer. Like I have told you, if I have a patient with a breast cancer and if HER2 is positive, then we subject the patient to monoclonal antibody like trastuzumab, pertuzumab, and there are more drugs which has come into this anti-HER2 family. These injections, medicines in the form of monoclonal antibody plays a significant role in controlling the cancer to spread further. Okay, increases the progression-free survival, thereby increasing the survival. Without this monoclonal antibody in a metastatic disease, the survival is extremely poor. And the problem with this monoclonal antibody is that they are a bit expensive. Not everyone can afford, and making available them at a government setup is also a challenging task for everybody. And it's a long treatment because it controls the cancer very well, but once it controls the cancer, you have to use it continuously, at least till further data is there or further progression. That's a problem. So the role of monoclonal antibody is of paramount importance for the patient survival in breast cancer. Next question, sir, can you please elaborate role of immunotherapy in triple negative breast cancer? Yes. So what happened, I'll tell you one thing. There are 4 important types of breast cancers: luminal A, luminal B, and then you have HER2 enriched, and then the 4th is the triple negative. Triple negative means your estrogen receptor is negative, your progesterone receptors are negative, and your HER2 is negative. So until recently, maybe by 2018, we had no option other than chemotherapy. Chemotherapy was the only lifeline. Then what happens, because of the discovery of the immunotherapy, since triple negative are highly aggressive in nature, there are no other pathways positive. Immunotherapy like atezolizumab was used upfront in the first line in combination with other drugs in a triple negative breast cancer, and has done a tremendous job. It has controlled the cancer very well. What do we do is that before subjecting the patient for immunotherapy, we generally ask for one important testing, which is called as PD-L1 testing. And if the PD-L1 testing is strongly positive, patients with the immunotherapy do extremely well. The cancers gets controlled. And the best part, advantage of immunotherapy in today's generation is that if a particular patient responds well to immunotherapy, the response is highly durable and long lasting. Okay, thereby giving the chance to the patient to survive. So this is what immunotherapy, only one immunotherapy drug has been approved right now in a triple negative breast cancers. And it's very expensive. The single drug costs you around 2 to 3 lakhs for a single session. And it is to be used for how long? As long as the patient is doing well, as long as the drug is acting very well in the body, you have to continue to use. Generally, we counsel the patient that if a patient is willing for immunotherapy, minimum 1 to 2 years of immunotherapy has to be taken into consideration because it's expensive. So you have to prepare the patient in terms of financial, because the immunotherapy may not act immediately. It may not show you the response immediately. It may take 6 months, okay, to give you the best response sometimes. Sometimes may even take 1 year. But once it responds very well, the response is excellent and long lasting. That's why we tell to our patients that to wait for 6 months to 1 year, and if you get a good response for a probably period of 2 years is important for immunotherapy. So I think this is sufficient from immunotherapy point of view in triple negative breast cancers. Cost of HER2 treatment, yes. So cost of HER2 treatment, we have trastuzumab. Trastuzumab has different companies, different brands. Today's session has been sponsored by Intas. Intas is one of the company which has its own trastuzumab molecule. And the best part about this Intas is that it is one of the cheapest and lowest price available in India. And many poor patients who think of a long treatment, we can give this option also. Overall, the cost ranges between 20 to 60,000, depending upon different brands and generics molecules that are available. Currently in India, we have at least more than 5 or maybe around 8 to 10 brands available for HER2 treatment. So each drug, all right, the SIF drug, only I'm talking about the drug, may cost to between 20 to 50 to 60,000 of HER2 treatment. This is, I'm talking about trastuzumab. In addition to this, there is another new molecule called as pertuzumab. We many a times use a combination of trastuzumab and pertuzumab, which gives a better response rate. But the problem is, once again, it's expensive. One pertuzumab injection is going to cost you 2.5 lakhs, and we give for a period of 1 year, okay, in an adjuvant setting. And in a metastatic settings, there is no finite number of cycles. If the patient is doing well, we continue the cycles. So that's the overall cost of HER2 treatment. I mean, like, it's expensive, and it requires a good counseling to the patient, and a good backup financial support is also required in this. Next question.
I think we'll take one more question.
Yeah, I've got plenty of questions here right now.
Yeah, that's why I said.
Okay, okay. Dr. Vinita Shetty, what could be the cause of recurrent breast abscess in a non-lactating females with a history of single full-term pregnancy? Okay, all right. So, very important. If a breast has recurrent breast abscess, first and foremost, rule out malignancy. Malignancy, cancer is the biggest mimicry, and it can mimic any other clinical feature which is looking like a benign. Once you have ruled out malignancy in this, then there are multiple things. What happens is that, okay, multiple recurrent breast abscess in a non-lactating woman, the anatomical structure needs to be taken into consideration, where you have to go more into the details, where the ductules, lobules, okay, there is a stasis or some underlying recurrent, infection that is happening leading to abscess, which needs to be carefully examined by means of sonography and detailed investigations by means of aspiration of the pus, and what is the underlying bacteria or fungus or whatever, and depending upon the culture sensitivity needs to be treated, and then it gets resolved. Okay, but be alert, recurrent breast abscess can be a sign of malignancies. We have come across such situations. So most of the times, if it's a benign breast abscess, they should get resolved. There is no question of having repeated again and again, I feel. Can monoclonal antibodies is given alone, I mean without the accompanying chemotherapy? Depends upon what is the setting. Okay, it can be given if it's an adjuvant settings. Initial 4 settings is given in combination of chemotherapy followed by only monoclonal antibody for 1 year. If it's a metastatic breast cancer, generally it is given in combination as long as patient don't have side effects. Yes, it can be given alone also, but the response is not that good as much as in combination. Okay. Is there a role of stem cell therapy? No, at present there is no role of stem cell therapy. There is one last question, if with your permission I shall take, so that they don't find it offending. Bashir, Dr. Bashir, does end route in triple negative patient? Dose and route. Okay, I'm sorry, what is the dose? I mean, which particular drug? Dr. Bashir?
No, he's one of the attendees, so he will not be able to speak up.
Perfect, perfect. No issues. All right.
Sir, I think Apurva has given the pricing.
Right.
So shall we wind up, sir?
Yes, 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 definitely.
Thank you very much, Dr. Pritam Kumar Jain. It was really an interesting lecture, and that the amount of questions coming up also shows the interest our delegates have taken into this topic.
No, it's important, I think. Thank you very much for showing
Yeah.
interest and asking actively questions. It's a broad topic, cannot be discussed in one single session, but I think I've done a fair enough job to give you a fair idea and outline about this.
Yeah. Okay. Thanks a lot, Dr. Jain. Also, we were any questions from the panelists, Dr. Borkar, Sachin.
Uh, just a comment regarding two questions which were asked. One is chronic or recurrent infection. So it can be due to bacterial infection in immunocompromised like diabetic or HIV or any other immune compromised status. Second thing, most commonly what we see is idiopathic granulomatous mastitis and tuberculosis. So those are the other causes of recurrent infections in the breast in non-lactating females. Lactating, obviously, it is due to the ductal blockage and then galactosile which gets infected. And another question which was asked, does fibrocystic disease change to malignancy? It usually does not change to malignancy, but it can have malignancy which was missed due to the fibrocystic disease, because that gives rise to densities which may not be seen properly on the mammogram and you may miss it. But as far as I know, there is no documented conversion of fibrocystic. But many times if you do a biopsy, you may find a malignancy which was present there, which was missed. So fibroadenomas or fibrocystic disease, these are the benign conditions that don't change to cancer, but they may have sometimes. Fibroadenomas are mimicked by a lobulated cancer, microlobulated cancers, which we see in mucinous cancer. So they may look like fibroadenomas, but on biopsy, they may turn out to be malignancy. So there are specific guidelines. Say what is the right staging of the mammography. Accordingly, we do the biopsies, and if biopsy is showing cancer, then treat them accordingly. But usually conversions are not seen so frequently. Those are not pre-malignant conditions. Pre-malignant conditions are if a TPI is seen, a typical lobular hyperplasia, a typical ductal hyperplasia, those are pre-malignant conditions which can convert to cancer. But per se, fibrocystic changes or fibroadenomas don't change to cancer. And someone had asked all the panelists to discuss about hormonal therapy, premenopausal and postmenopausal. I think Pritam would be better at answering that question than me.
I think Dr. Sachin wanted to ask something.
So already.
What are the chances of male CA breast?
1% of all the breast cancers are male CA breast cancers. They are rare. Usually they are diagnosed the same way as female. So mammogram will be done. The risk is higher if their BRCA mutation is running in the family. And treatment is usually with mastectomy. If it is, because there is not much of breast tissue, it usually involves the pectoralis muscle. So we may have to excise a part of the muscle. Nowadays, people are doing conservation also if detected early. But you have to be aware that mammogram is still investigation of choice, not that males cannot have mammogram. But we don't recommend a routine screening because it is easily palpable in the male breast because there is no breast tissue. And treatment again remains the same. Chemotherapy, hormonal therapy is given in the male breast cancer also. Pritam can elaborate on that.
Yeah, I mean, like it is to be treated same like any other breast cancers because most of the times they are hormonal positives and same like giving hormonal therapy and chemotherapy. You don't differentiate much. Only thing is because of the less dense breast tissue, it is presenting more in an advanced stage at an early itself.
Shall we go for the Thanksgiving?
Dr. Jain sir, there are some questions I guess in the question answer session. If you want, you can just type the answers in brief.
Yes, yes, sure, I'll do that.
We have come to the end of this program, and we are lucky to have the director of CGP IMA Maharashtra State, Dr. Ravindra Kute, for this program. He heard the program fully, and he's appreciated it very well. Thank you very much, sir, for your presence. Now I tell Dr. Sachin Patarkar to propose the vote of thanks.
Yeah, good afternoon. BC Kalmar, Dr. Prabha Yadav, Dr. Pritam Jain, Dr. Nikhilesh Borkar, Mr. Sanket Barle, our knowledge partners for the day, Intas Pharma, MSD Pharma, Sir HN Reliance Foundation Hospital, Mr. Deepan Mehta and Mr. Chirag from DigiShield, who have given us the platform for this webinar and handle all technical details. At the same time, I am very much grateful and thankful to all the participants for joining us for this webinar. Thank you very much.